Good evening for dear colleagues and friends. You are very welcome to participate in our session about pancreatic cancer. I am Andrei Lukashenko from the National Cancer Institute, Scientific Director. I'm also the head of the Ukrainian Society of Surgical Oncology. Today's event is affiliated to our Association of European Surgical Oncology, and with a great pleasure I want to present our very beautiful and kind Veronika Patsko, Secretary of Ukrainian Society of Surgical Oncology. She's also the head of our clinical oncology department. I think it is the best way when the surgeon will do presentation and oncologist will comment. And one more time, I want to be very thankful to our participants from United States and from all over the world. And we are starting.
And I also would like to introduce Chief of company Syria, who helped us with organization of this event. So can we please start with talk of Nicholas Claverio?
Yes, perfect. Thank you very much. Thank you very much for the kind introduction. I guess you can hear me correctly. So it's a pleasure. So it's a pleasure to make the introduction of this very important event on the team approach for pancreatic cancer. We're very happy to support the educational processes of Ukraine over the long term, and now even closer, with the oncology community, and despite the very difficult times, of course, in the country. So I would like to introduce, briefly for everybody. Who's Servier as a company and what we do in the country. So next slide, please. So as you can see, the company has a wide geographical footprint. We are present in 150 countries. We have more than 16. We have 16 exactly manufacturing sites in 11 countries, and Servier also. We are conducting as well clinical research in different parts of the world, and actually Ukraine was also, before the war, a very important center for clinical research for us. But we have 15 of these clinical hubs around the world, which are helping us to have a general footprint when it comes to drug development. Next slide, please. As you will see on the next slide. Yes, thank you. As you will see here on this slide, this is the brand new research center of Servier, which was built in the south of Paris in a very important scientific hub, which is called Paris-Saclay. So that's a new research center which was inaugurated last year in January 2023. So it's a very strong commitment from the group to continue its ambition in terms of generating innovation, gathering teams of research from different therapeutic areas. We even, in this new research center, created a startup incubator. So part of the research center is dedicated to external companies. The objective is to innovate even more, creating a network between different actors of the healthcare world. And this is also, of course, providing a very agile methods. So as you see here, this innovation, of course, translates into products in development, in preclinical and clinical development. Cardiometabolism was historically the strength of Servier. So we have many products already on the Ukrainian market which address those diseases. But today we are here together for pancreatic cancer. And you can see that the oncology field is now the main field of Servier when it comes to research. We have many projects. This is where we have the most important number of projects in preclinical and in clinical research. And we have the ambition as well to develop ourselves and to bring innovation on the market in Ukraine in neuroscience and immunoinflammatory disease. Next slide, please. So we're very proud because the company was actually recognized very recently in France for this innovation. There was actually by the Office of Patent a classification of the most innovative companies between 2002 and 2021, and Servier was ranked during this event as the third most innovative company in oncology during the past 20 years. So it's really, it's a very important recognition for us because we had this turn into oncology for less than 10 years. So it shows already, let's say, the benefit and the close collaboration with the cancer community over those years. Next slide. Next slide, please. I think it's going to come. Thank you. We have a very close partnership with patients. Some example. We are, of course, glad to have educational project like the project of today with the educational community. We do it, of course, internationally, but with different societies, but also nationally in Ukraine. And as I said, this conference is a good demonstration. Next slide. Patients are, of course, one of the main priority for us. And in the next slide, I would like to share with you some example of what we do, how it translates here in Ukraine. We support a very important project, which is called the Onco Awareness Project with the National Cancer Institute and the Ukrainian Society for Oncological Surgeons. The project, you may have heard about the project, aims at supporting the awareness of patients and their relatives regarding GI cancer and to help doctors to communicate with patients, find the right words to communicate about the disease. So the first cycle of the program, which was initiated for colorectal cancer, really addressed the question about diagnosis, about treatments, about psychological support. We understand how it's important, in this kind of support for the patient, and especially for patients with this type of hard-to-treat cancer. So this is why we've decided now to go this year with a second wave, which is now addressing pancreatic cancer. For the past year, we had more than 30,000 views for the different videos that you see on the slide. So it shows really the usefulness and the power of this kind of program. Next slide, please. Of course, we are in a war. The company is very much dedicated in supporting the country. So Servier is doing everything possible, of course, to support the country in terms of humanitarian support, humanitarian help. The Servier Group allocated funds through the foundation, its own foundation, which is called Mécénat Servier, to help the country. And as of today, we've been investing in support more than 13.5 million euros. Servier Ukraine, on its side, is also actively involved in supporting patients from the beginning of the war. The company has already provided assistance to more than 385 hospitals around the country since February 2022, including the most affected regions, of course, on the eastern part of the country. So the contribution of Servier Ukraine was around 47 million hryvnia. And this is actually also containing several million which are dedicated to oncological products. Next slide. So thank you very much again for the opportunity to introduce this meeting. I would like to wish you a very fruitful discussion, very fruitful collaboration, and again stress the commitment of the company to keep supporting the country. And of course, glory to the heroes, glory to Ukraine. Thank you very much and have a nice meeting.
We will start with our course. First of all, I would like to thank Ukrainian defense forces who helped us to survive and to live and to study further. And as every oncological diagnosis starts with pathology, so we will start our course with pathologists from Northwestern Memorial Hospital, which is located in Chicago, and Dr. David Escobar, who is pathologist specialized in GI tumors, will start his talk on pathological features of pancreatic cancer. Hello, Dr. Escobar.
Hello, good morning, everyone. I'm glad to be here this morning, and I first want to start out by expressing my condolences and sympathy for your country and what you are going through, and I hope that your victory is soon coming. But this morning we're here to talk about pancreatic cancer. And as you said, the diagnosis always starts with the pathology. So to begin my talk, I wanted to first say one or two words about the role of the pathologist or the Department of Pathology in multidisciplinary cancer care. Obviously, the first thing we do is establish the diagnosis of pancreatic cancer through histologic examination of diagnostic tissue, either through biopsy or resection. Once the diagnosis is established, we further characterize the tumor to identify prognostic features, which will impact on the patient's care for either oncologic or surgical approaches. Second, the pathologist may be involved in selection of additional immunohistochemical or molecular biomarkers to identify therapy, especially in the age of personalized medicine. This is an incredibly important feature of the pathologic workup, including biomarkers like HER2 expression and PD-L1 expression for oncologic regimen. After treatment, pathologists may also get involved in the post-therapy response or for recurrence monitoring, but that's not the focus of today's talk. Today's talk, we will just focus on diagnostic tissue examination and tumor features for pancreatic cancer. Obviously, this is a very large topic that minutes. So I will focus on cystic pancreatic neoplasms, emphasizing those that have a malignant potential. I will briefly discuss our institutional approach to diagnosis, especially on limited biopsy specimens, but we will not be discussing pancreatic neuroendocrine tumors or neuroendocrine carcinoma today. The WHO currently classifies cystic neoplasms of the pancreas as follows. On the low grade end, we have serous cystic adenoma and solid pseudopapillary neoplasm. And with more malignant potential, we have mucinous cystic neoplasm, or MCN, and intraductal papillary mucinous neoplasm, or IPMN. These, again, each have their various associations with risk of invasive cancer or malignancy. So let's talk about those in a little bit more detail. Serous cystic adenoma is a rare cystic neoplasm, accounts for about 2% of cases. The pathogenesis of this tumor relates to aberrant signaling in the von Hippel-Lindau and hypoxia-inducible factor pathways. However, it has a very good prognosis, especially for small lesions, and only rare cases progress to invasive growth and or metastasis, frequently to liver. In fact, some believe that metastasis is the only feature that you can use to distinguish an adenoma from an adenocarcinoma. Grossly, these lesions are very unique with this characteristic multicystic spongy appearance to the lesion with a central scar. And the cyst spaces are lined by these very bland neoplastic cells with characteristically clear cytoplasm. The solid pseudopapillary neoplasm is also somewhat rare, about 5% of pancreatic neoplasms. These occur predominantly in young women. The cell of origin for these is not clear. Because solid pseudopapillary neoplasm has also been described in the ovary and testes, there's a possible embryologic origin. The systematic mutations in beta-catenin and downstream activation of the Wnt pathway. These are currently classified as low grade. They usually have a long disease-free interval after surgical resection. And if there's malignant features, it's usually associated with an undifferentiated component. Grossly speaking, these lesions, pseudopapillary neoplasms, typically have a variable cut surface with areas of hemorrhage and a lot of cystic degeneration, creating these pseudocystic spaces. Microscopically, we see nests of tumor cells that have undergone extensive degenerative change, leaving behind these cystic spaces. The reason these cells degenerate is that they tend to survive well when they're located very close to vessels. So they have this clinging appearance next to fibrovascular cores, and away from those fibrovascular cores, the cells often go degeneration and ischemic type necrosis. The cores of the fibrovascula in this neoplasm can either be fibrous or contain this pale gray myxoid material. And then characteristic of the degenerative changes in this tumor is that as the tumor cells degenerate, they form cholesterol clefts, which are then ingested by multinucleated giant cells. As I mentioned, nuclear beta-catenin or aberrant beta-catenin signaling is the hallmark for this tumor. So identification of nuclear staining for beta-catenin supports this diagnosis. Before I get into the other cystic neoplasms, I did want to stop and go through an illustrative case to talk about the rest of our cystic neoplasms. This is an invented history, but a typical patient might be a 45-year-old female who presents with abdominal pain. Imaging might show a 3 or 4 centimeter lesion in the pancreas with unclear relationship to the pancreatic duct. And this patient could undergo an endoscopic ultrasound-guided fine needle biopsy. In the biopsy sections under the microscope, a of monotonous epithelial cells. So these appear to be clonally related to each other. They have a basally oriented nucleus, and they have a mucinous cytoplasm toward the apex. These cells are sitting nicely on a fibrotic stroma with no clear invasion of those cells into the fibrotic stroma. So we have no clear evidence of malignancy at this moment. Elsewhere on this slide, those mucinous epithelial cells were detached from their stroma and were just free floating around the slide, floating in pools of blood. So we have detached fragments of mucinous epithelium, minimal stroma present, so we cannot comment on the invasive malignant features. And at this point, our differential includes a mucinous cystic neoplasm or an intraductal papillary mucinous plasm with or without an invasive component. It's hard to tell on the biopsy that we've seen so far. So mucinous cystic neoplasms, these account for 10 to 15% of cystic pancreatic neoplasms. The vast majority of these occur in women. Small lesions are non-symptomatic, often incidentally discovered. The pathogenesis, again, for this tumor is not exactly clear. An ectopic ovarian tissue origin or an embryologic origin has been proposed, but this cannot explain the small proportion of cases that occur in genetic males. But more importantly for today, about 15% of these are associated with invasive carcinoma, and therefore extensive sampling in the pathology lab is warranted. Molecularly, these do show somatic mutations in KRAS about 50% of the time, with very rare p53 mutations. Grossly, these cysts do not communicate with the pancreatic duct. That's a key finding, and often there's degenerative changes in the fibrotic wall. Histologically, these cysts are characterized by, here's the luminal space here in this tumor, and deeper down we have this fibrotic wall with a few residual pancreatic elements, including some islet cells and some pancreatic ducts. But the cyst lining is where the key diagnostic features are, and we have a very flat to cuboidal lining, which we'll look at higher power, and then this very dense stroma underneath it, which includes inflammatory cells, mostly lymphocytes, and bland spindle cells. Looking at closer power, here is the bland cuboidal cells, often with a suggestion of mucinous differentiation, here typified by some goblet cells. Again, the stroma has a few lymphocytes, as well as these very bland spindle cells that on immunohistochemistry are positive for estrogen receptor in the nucleus. In terms of invasive and malignant potential for these, as these undergo a sequence from bland or benign mucinous cystic neoplasm, they follow a sequence where they will first show low-grade dysplasia, here typified by elongated nuclei that are lifting off the basality of the epithelial layer, so they're starting to lose their polarity. When they proliferate and start to form complex architectural features such as micropapillae or branching or an interanastomosing structures, we call that high-grade dysplasia. And the finding of both of either low-grade or high-grade dysplasia in MCNs is the strongest pathologic risk factor to identify carcinoma in this specimen. Carcinoma in this case would be typified by the mucinous epithelial cells forming these sharply irregular angulated glands that are invading through that fibrotic wall of the cyst and into the pancreatic parenchyma. On the other hand, intraductal papillary mucinous neoplasm is defined as a visible pancreatic lesion comprised of an intraductal epithelial proliferation that either involves the main pancreatic duct or side branch or branch ducts. There appears to be an age-related component to this tumor's pathogenesis, with about up to 7% incidence by age 70. Molecularly speaking, these neoplasms also feature frequent KRAS mutations, 6 to 80%, as well as GNAS mutations. RNF43 mutations are found in about 50% of cases. Interestingly, P53, the incidence of finding these molecular alterations increases with the severity of the dysplasia or invasive component, with 10 to 40% being identified in high-grade dysplasia IPMNs, and 50% or more being found in cases with an invasive component. Grossly main duct IPMNs are typically in the head of the pancreas. These are ones that are often associated with dysplasia and carcinoma. Branch duct IPMNs, often located in the uncinate and have a multi-lock feature invasive carcinoma. For histology, the characteristic finding is an intraductal proliferation of mucinous epithelium, which may actually be flat, but as its name implies, it frequently forms microscopic or macroscopic papillae. So here's a typical example. Here's a section of the pancreatic duct. Here the wall is a little bit fibrous and altered by the neoplastic process happening, but the neoplastic process is characterized by these proliferating mucinous epithelial cells forming numerous papillae, and these papillae extend into and completely fill the lumen of the pancreatic duct. There are three general subtypes to this. The gastric subtype, which is so called because the mucin intracytoplasmic resembles the foveolar mucin that is identified in gastric tissue. So this is gastric type IPMN, very usually low grade. Intestinal type IPMNs resemble enteric mucosa with frequent goblet cells. These are very frequently high grade with invasive carcinoma identified. The rarer type is a pancreatobiliary type, again, so named because the mucinous cells here resemble ductal epithelial cells found elsewhere in the pancreatobiliary tree. These are almost always high grade with invasion. So returning back to our case number one, this patient did undergo a surgical resection. And on the resected specimen, we again redemonstrated areas with mucinous epithelium in both a low-grade configuration as well as a high-grade configuration. But we additionally identified areas where the mucinous epithelium was forming angulated, invasive glands that were entering into the pancreatic stroma. So the final diagnosis for case number one was an IPMN with an invasive adenocarcinoma component. Which brings us again to the meat of our conversation today's pancreatic ductal with and it doesn't matter whether you are a Western country or a developing country. In the United States, 65,000 new cases were estimated in our most recent year, 2023, with almost 51,000 deaths. And some predictive modeling suggests that pancreatic cancer may actually become the second leading cause of death by 2030. And although there are environmental and modifiable risk factors, pancreatic ductal carcinoma is largely driven by molecular mutations, whether those be germline or somatic. And the big four are ones that we have already talked about: KRAS, P53, CDKN2A, and P16, as well as the transcription factor and tumor suppressor SMAD4, which is inactivated in 50 to 60% of the cases. Obviously, the molecular features of pancreatic adenocarcinoma deserves its own topic, and in fact, it does have a session later in this symposium. Grossly speaking, invasive ductal adenocarcinoma typically forms a white tan mass with irregular infiltrative borders that often you can see infiltrating into what remains of the normal pancreatic parenchyma, which is over here. There may or may not be upstream ductal dilatation, and there may be visible invasion of this mass into adjacent organs, such as the duodenum. Histologically, we tried to identify haphazard infiltrative growth of ductal type glands into the pancreatic parenchyma. The pancreatic parenchymatic stromal response, which we in the pathology lab call desmoplasia. This combination of features is essentially diagnostic for pancreatic ductal adenocarcinoma under the microscope. And very helpful would also be to find features of invasion into the peripancreatic fat, which is where we most frequently identify things like lymphovascular space invasion or perineural space invasion. Here's a typical example with the malignant angulated glands in the pancreatic parenchyma. Here, eliciting that fibroblastic and inflammatory response. We can also see evidence that these tumor cells have entered into the perineural space, here existing right next to this small caliber nerve. As well, here we have additional malignant glands that are very close to a medium to the find ductal epithelium in this close proximity to such a large vessel. So this finding is also very useful for diagnosing pancreatic cancer. Here's another example with a more mucinous epithelium, very much like the IPMN case that we just discussed, again demonstrating perineural invasion and tumor cells touching and abutting this medium-sized vessel. As I mentioned, in the peripancreatic fat, we frequently identify lymphovascular invasion. Here we have a lymphatic vessel lined by endothelial cells, and within the lumen of that space, we have malignant mucinous epithelium, indicating that the tumor has already entered into the lymphatic system. And once that has happened, the tumor may freely travel and end up taking up residence in regional or even distant lymph nodes. Here is a lymph node with a fibrous capsule and a residual germinal center, but the bulk of the parenchyma being involved by a metastatic pancreatic ductal neoplasm. I did want to talk a little bit about immunohistochemistry. Your pathology reports may frequently discuss an immunohistochemical workup. For pancreatic adenocarcinomas, because these tumors are derived from ductal epithelial origin, they are frequently cytokeratin positive, and the profile usually includes things like cytokeratin 7, 8, 18, and 19, but unfortunately this with and cholangiocarcinomas and bile duct carcinomas. These tumors can be variably positive for various tumor markers. We don't find these very helpful in our practice, and can be very positive for lineage markers such as CDX2, which is strongly positive in colorectal tumors, but can be patchy positive in pancreatobiliary tumors as well. So we find that these immunohistochemical stains have essentially no utility in primary resections, but in biopsy samples, we can simply use these to confirm ductal pancreatic origin if the profile fits, but we cannot use this profile to distinguish pancreatic from other GI or cholangiocytes. Immunohistochemical stains that are much more useful include things related to molecular alterations underpinning the tumor's biology. So I mentioned that p53 is genetically altered, and we find that the protein product p53 is altered in its expression in up to 80% of cases. Similarly, the SMAD4 transcription factor is lost, and this can be detected by immunohistochemical methods in about 50% of cases. I'd like to illustrate that most recent point with another case. This is another invented history of a 65-year-old male. His imaging showed a 4-centimeter mass in the head of the pancreas that was abutting and involving the pancreatic duct and did cause dilatation. And he underwent an MRCP with biopsy. And in his case, the biopsy showed the pancreatic acini here. So this is the normal pancreatic parenchyma. Right immediately adjacent to it was this area of kind of moderately atypical cells, but in such close proximity to normal pancreatic parenchyma that it wasn't immediately obvious whether this was a part of the neoplastic process. Elsewhere on the biopsy slide, we again identified those detached fragments of mucinous epithelium, but not clear invasion. So we did cut deeper levels into this tissue to further investigate. And then we did eventually find some of these atypical glands now more obviously embedded in a fibrotic stroma. But to kind of help us clinch the diagnosis in a borderline case like this, we did find that immunostaining for p53 is very useful, both in the embedded glands in the fibrotic stroma, as well as in the free-floating detached epithelium, meaning that this was a final diagnosis of invasive ductal adenocarcinoma. So our approach to ductal carcinoma on limited specimens is due to the fact that the biopsy fragments are often limited. We may be looking at anywhere from 10 to a few hundred neoplastic cells with a lot of background. And so we really need to attune our eyes to typical diagnostic features, such as the ductal type atypical glands in a fibrotic or desmoplastic stroma. If the biopsy needle happens to transverse an area of lymphovascular or perineural invasion, that will obviously be very helpful. But at least in our institution, we make liberal use of supportive immunohistochemistry, such as p53, SMAD4, to help confirm the clonal or neoplastic nature of the specimen, especially in borderline cases. I'd like to proceed by showing yet another 70 mass who undergoes ERCP. In this case, her tumor shows two areas of morphology. One, which we'll look at in higher power here, appearing to show some gland-forming structures with luminal spaces, as well as other areas that show a more solid or nested configuration with no gland formation. This is merely showing again that we have luminal formation, so this appears to be a glandular component or adenocarcinoma component of the tumor. Whereas the solid area shows, again, back-to-back cells and an ample amount of eosinophilic cytoplasm, nice centrally placed nuclei, and very prominent nuclear borders, as we can see through here. This type of morphology is very reminiscent of what we see in squamous cancers and squamoid cancers at other sites. And compatible with that, lineage markers for squamous differentiation, including P63 and P40, were diffusely positive in that solid component of the tumor. So our final diagnosis for this biopsy was invasive adenosquamous carcinoma. And I bring that up to start discussing a few histologic subtypes of pancreatic adenocarcinoma. There are two reasons to histologically subtype adenocarcinoma. One is so that the pathologist is aware of the array of morphologies they may encounter and nevertheless arrive at the correct diagnosis. But perhaps more important is that some of these histologic subtypes are associated with different prognosis compared to conventional ductal carcinoma. And so it may be important to report these features to aid in patient prognostication. So in the case of adenosquamous carcinoma, these are carcinomas that have a clear ductal component with at least 30% of the tumor being a squamous component. These have poorer prognosis compared to similar. A small selection of additional subtypes is shown here. Colloid carcinomas are pretty much defined by having abundant extracellular mucin with free-floating neoplastic cells. Their prognosis is better than conventional ductal adenocarcinoma. Medullary carcinoma is a very poorly differentiated tumor, frequently showing loss of MLH1 and PMS2 in the DNA mismatch repair protein apparatus, and these overlap with EBV-associated poorly differentiated carcinomas. There is a new addition to the 2019 classification for pancreatic tumors in the subtyping category, and that's micropapillary carcinomas, where 50% of the tumor is comprised of very small solid nests. Those look like this. Very small infiltrative nests where the nuclei are located on the outside of these nests. If 50% of the tumor is comprised of this morphology, we call it micropapillary. This is associated with very poor prognosis and very high rates of lymphovascular invasion. In what remains of my time, I'd like to very quickly show one final case, which is a patient with a slightly different demographic than we've been talking about. We now have a 20-year-old male with no prior clinical history who presented with abdominal pain, and his MRI showed a very large 15-centimeter pancreatic mass with invasion of the duodenum, clear malignant features, including abutment of the superior mesenteric artery, and he underwent an ERCP as well. The biopsy showed entirely lesional tissue with no background parenchyma, comprised of nests of abundant tumor cells with a very high NC ratio, and abundant tumor necrosis throughout. On higher power, we can see that these tumor cells are very solid back to back, but have kind of a discohesive appearance to each other. That these malignant tumor nuclei have frequent prominent nucleoli, have a decent amount of eosinophilic cytoplasm that appears to be pushing the nucleus off to the side in several instances. So the nuclei are eccentrically placed with eosinophilic cytoplasm, frequent intracytoplasmic vacuoles that contain these pale hyaline globules. This type of morphology is actually very reminiscent of soft tissue tumors, especially skeletal muscle tumors like rhabdomyosarcoma. So we call these rhabdoid morphology. This tumor was confirmed to be a carcinoma due to diffuse keratin expression, but of note, the chromatin remodeling protein called SMARCB1, also known as INI1, was completely lost in the tumor cells, but retained in the differentiated carcinoma. Which brings me to my final point, which is that we have to always be on alert for emerging classifications for pancreatic carcinoma. Molecular analysis is increasingly being performed, particularly on poorly differentiated and undifferentiated tumors across the GI tract, and have identified, as illustrated here, a subset of tumor with a deficiency in the switch sucrose non-fermenting complex of proteins. Histologically, these are comprised of poorly cohesive tumor cells with a rhabdoid morphology, as we illustrated. The various members of the chromatin remodeling complex may have their own prognostic impact. SMARCB1 is of unclear prognostic impact, but its neighbor, SMARCA4, does appear to have a worse prognosis when it is lost, but may we be progressing toward a trend toward molecular-based classification schemes in the future? We will see, and time will tell. So in conclusion, histologic tissue examination by the pathologist remains paramount for the diagnostics and prognostication of pancreatic carcinoma. The pathologist must use an array of histologic and immunohistochemic features to achieve a diagnosis, even in limited biopsy samples. As we've talked about today, mucinous cystic neoplasms remain an area of diagnostic challenge. But that our hope is that histologic and prognostic classification is useful for patient therapy. And as molecular understanding improves, we may progress toward a molecular-based scheme. Inviting me, making the connection for my mentors here at Northwestern University. And I would like to take your questions if there are any.
Thank you very much, Dr. Escobar, for this profound talk. As always, for clinicians, the topic of pathology is just another world in pink and purple. But I have, meanwhile, we don't have questions from online, but I have questions from myself. In your center, do you participate in tumor boards and influence somehow on the strategy of treatment during your tumor boards for patients with pancreatic cancer?
Absolutely. Here at Northwestern, our tumor board is comprised of oncologists, surgeons, pathologists, as well as some support staff, including genetic counselors and patient support. And the role of the pathologist in the tumor board is to ensure that every new case of pancreatic cancer has undergone appropriate biomarker testing. And at our institution, we frequently perform HER2/neu testing for those targeted therapies, as well as PD-L1 testing and MSI testing, of course. And then if the oncologist will request it, we also will do a 500 gene molecular panel, which will look for somatic mutations, as well as calculate a tumor mutation burden, particularly for MSI high tumors. And then at the discussion for the tumor board for each patient, and presented of what the diagnosis is, what the prognostic factors are, whether it's an aggressive histologic subtype, whether additional aggressive features were identified on the biopsy or resection, what the biomarker results were, and what those may mean for therapy options, what the molecular or next generation sequencing results were, and whether those impact on either available therapies or enrollment into clinical trials.
And in case we don't have any more questions, and so we're like enough time, so I would like to present. Oh, we have one more question from auditorium.
Yeah, if it's possible, one question. I saw from your clinical cases that you become more satisfied from material from EU's biopsy, because in guidelines it's still limited because of limited quality of material. In Western, I saw that it's becoming more and more popular. And give us your pathological meaning. Is it good enough to do all this morphology which you present? I mean, endoscopic ultrasound.
I'm just making sure I understand the question. Is the question is whether on or the material is enough to make histologic subtype diagnoses?
From ultrasound endoscopy, yes. I mean,
it depends on the quality and amount of material that we got, so it certainly can vary by case. On very limited biopsy specimens, we may have to do things like cut deeper into the tissue and make use of our immunostains to merely arrive at the diagnosis of neoplasia without being able to comment on whether it is malignant or not. And in such cases, we will nevertheless look into the imaging findings and do our best to correlate. But sometimes on limited samples, the most we can do is say that we have a clear clonal proliferation of mucinous cells. Mucinous neoplasms are on the differential, but we don't have enough evidence to call invasion outright in the pathology lab. Other tissue specimens have a lot more tumor volume, and the malignant features are much more clear. So it certainly can vary by case.
Thank you very much for your response, and thank you very much for your talk. We really appreciate that you've been live with us today. And I would like to continue with the treatment. So as we all know, I guess the main pancreatic cancer is a surgery. So I'd like to introduce a surgeon from National Cancer Institute, who is also president of Ukrainian Society of Surgical Oncologists, Dr. Andriy Lukashenko, who will talk with us about techniques on treating pancreatic cancer.
Thank you one more time for participation, and we will start from some statistic from, it doesn't work, I think, no? This one. Still no?
Sorry for some technical issues, so we'll just start.
Okay, thank you. Approximately 4,000 new cases per year, and from them even morphology get less than half of the patient, and the special anti-cancer treatment could get only 1/3 of the patient. From them only 7% pass through the surgery, including bypass procedures. It means it's highly demanded technically, and also in support and recovery. But the main problem is that most of our patients at the present get already distant metastasis or very bad general condition to pass through the even morphological procedures. Of course, the radical surgery are the best things, and only one thing which allow patient to be treated from cancer. Now, for right pancreatic cancer, it's a Whipple procedure which include removal of the pancreatic head, duodenum, distal gastric, gallbladder, and after that, complicated reconstructive part. For the left pancreas, it will be distal pancreatic resection with the spleen. It's much easier, and in most cases, it could be performed laparoscopically. And the third general procedure is total pancreatectomy, when we have to remove all the pancreatic, body, tail, and head in one complex with duodenum, with the spleen, and after that, reconstruction. This kind of procedures usually we perform in cases of previous heart diabetes or in hard pancreas and soft pancreas, in an expectation of possible high level of postoperative complication. But this is the paper actually from this region where we now, from Ivano-Frankivsk, where the authors shows us that in low volume centers, the level of postoperative morbidity after Whipple procedure could be really high. And from the literature and from guidelines, we know that to be safe center to perform Whipple procedures or such complex operations, you have to do at least 5 Whipples in one hands annually. It will decrease the level of general complication to appropriate line. Even now in Ukraine, it's a discussion, have to we do radical surgery for right pancreatic tumors or just bypass procedures and chemo. This is the publication from Netherlands where they show clearly that only radical surgery for resectable pancreatic cancer allow us to achieve 5-year survivalship. And the line of discussion for now in high volume centers, for example, from this paper from Germany, last review from 2023, that's not a mortality or high morbidity level, it's a problem. The problem is that after surgery, some patient can have delayed gastric emptying as a prominent complication after Whipple procedure, which delay discharge, and we have to resolve this problem in the nearest future. When we start to do pancreatic surgery, a pancreatic program in National Cancer Institute in Kyiv in 2007, we even start to do surgeries for pediatric cases. It's much more complex in approach of anesthesiology, recovery, laboratory support, and such things. Of course, kids have less aggressive tumors and could be treated much easily, finally, which we find in this experience. This is our case of 2 years, small girl with pancreatoblastoma. We did a Whipple procedure with linear SMV resection. And after that, her mother sent us her pictures from each year when kids start to grow. And finally, she is now finishing school. And we're afraid of some delay problems like exocrine or endocrine insufficiency after Whipple. From the literature, it could occur in from 7 up to 17% in elderly population. But here we even did reconstruction and didn't find, after a few years after Whipple, atrophy of pancreatic remnant of duct dilation. And there is no any. For now, we have more than 10 in our experience such cases for kids Whipple procedures. This is now the group of patients where we do laparoscopic Whipple. It's as previous lecture shows us, solid pseudopapillary tumors in women and as well as some neuroendocrine tumor, because all the pancreatic adenocarcinoma is usually much advanced, and we have to do advanced surgery. And actually, what kind of results we can get from the best surgery for the best patients? This is the data from Memorial Sloan Kettering, where actually Whipple starts to do this famous work and propose his operation. This is the pathological analysis of final result compared to decades where they start to do these procedures early and then further and further. And this is the limit, the 2 years, 24 months. This limit, they can't break through even now with surgery alone. This is the same data from 2016, the same data from another very high volume centers from Johns Hopkins from the United States, also 24 months, 2 years, a median of general survival. And also the huge number of cases from MD Anderson Center. And you can see here, it's for resectable pancreatic cancer, stage 1-2 surgery only could give us 2 years of median of survivalship. Stage 3, it's a year and a half. The possibility to live more than 5 years for pancreatic only around 20%. It's much better for the tumor of the biliary duct or ampulla or duodenum. This is experience from Johns Hopkins after Whipple procedures. This periampular tumor also need to be treated by Whipple procedures, but the results much better than the ductal adenocarcinoma of pancreas. It's the worst prognosis. But for those patients who survive after 5 years, the chance to live more than 10 years it's up to the 60%. Okay. Could we improve our surgical result to be more aggressive, to do extend lymphatic dissection? We start to do this approach in 2008 and did for 50 patients. It's para-aortic dissection after Whipple or after left pancreatic resection. But our results, as well as results from, I don't know, it's no, okay. And the very famous paper from Mayo Clinic, they also analyzed their experience from extended lymph nodes dissections. There is no evidence and no benefits in long-term survivorship, because the patient in both groups, even in positive lymph nodes, gives us this. Okay, let's move from surgery to combined treatment, how the medication could improve our surgical results. First, data from adjuvant treatment shows us some promising percentage in prolonged of overall survivorship. This famous trial where we compare postoperative gemcitabine with standard observation, it shows us almost the same, 2 years, 22 and 8 months in the group of gemcitabine, but statistically better than just observation. After that, there was a trial from Japan where they use their famous S1 treatment, which they use almost for all GI cancers as adjuvant, much better than the gemcitabine, but these results could be achieved only in those populations. There is no signs of such possibility of final results in Western countries. And in other trials, there was not beneficiary in both groups, combined treatment, adjuvant, and monotherapy with gemcitabine. The same data 2 years after surgery. First, and the prominent trial which break through this 2 months, even in a comparative group, where we achieve almost 3 years after surgery using only gemcitabine, and almost 5 years, 4 years and 4 years and a half after a triplet, a very hard treatment, but procedures. Compared to other previous treatment, it's really prominent trial, but in my meaning, the base of this trial was very precise staging before estimation the whole treatment strategy. The protocol of CT and MRI from this trial become the standards of staging for pancreatic cancer. You can see here the very, very density slices for CT and MRI. The main point to divide those patients who are already metastatic. And finally, what interesting now is a complete neoadjuvant approach, as well as for the gastric cancer, as well as for a total neoadjuvant approach for rectal cancer, the probes for pancreatic cancer, how preoperative treatment could improve our operative results. First, meta-analysis from different non-randomized trials shows us some promising results, and then only for pancreatic cancer we have this classification, borderline resectable pancreatic cancer, which attached to the main visceral vessel, and that's why it could be hardly radically treated. Advanced tumor, non-resectable tumor to resectable. From some non-randomized trial, we see that the possibility to improve resection up to the 50% could be. And some trials for borderline resectable pancreatic cancer shows us that after neoadjuvant treatment, one resection could be achieved in more than half of the patients with overall survivalship more than 3 years. But if we took from this patient the group who will be finally resected, And this prominent group, biologically prominent, who respond for the neoadjuvant treatment, the overall survivalship could be up to the 5-year median of overall survivalship. This is a very interesting trial from Germany and England, few centers which do 4 arms, upfront surgery, 2 groups of chemotherapy, and 1 group of chemoradiation. Finally, they analyzed their 1-year results, and the worst group was when the surgery was chosen as a start. This is our patients with a border resectable pancreatic cancer, which is usually attached to portal vein or superior mesenteric vein or superior mesenteric artery. After a few cycles of FOLFIRINOX, it starts to shrink, but the tendency, I don't know why, is always in the direction to the main vessel. Even if the tumor shrink, it shrink to the vessel, and you have to be prepared even in this such beneficiary cases to complex surgery with vascular resection. This is the case of tumor with positive lymph node number 14. Chemo, but we still need to do surgery with venous resection. We routinely use intraoperative ultrasound to define how dense the tumor to the vascular wall and which type of resection we have to choose. In this case, it was type 2. We use Nakao classification to define the type of vascular encasement. And in such attachment, we do linear vein resection. When the encasement more than 180%, we do circular resection for Whipple, and the same situation for distal pancreatic resection. And at this year, it was presented on ESCO, the comparative results in approach for arterial resection. It's much harder, first of all, from tumor pathology, because the superior mesenteric artery is very dense with a high number of neural fibers. And if the tumor attached to the artery, it's usually involved these fibers. And from the pathological publication, if the tumor attached to the neural wall, it gives us usually a distant metastasis to the liver or other organs. This means this results from the very famous center from Nagoya, from Japan, where they do arterial, venous, and combined resection for advanced pancreatic cases. And this is the line for portal resection. Oh, sorry. This is the line for portal resection. The curve almost the same as for the localized pancreatic tumor. If you remove the portal wall or perform portal resection completely, the result could be the same. The radical resection not so better than chemotherapy alone, and for now this is the standard. Arterial encasement, it's a contraindication for radical surgery. And if you do arterial resection from the multivariate analysis, you put the patient in twofold higher danger for death after this surgery because of some lethal complication. And finally, at this year, it was presented result of neoadjuvant approach for resectable pancreatic cancer without any encasement in vascular wall. This was trial from North countries, from Norway, Sweden, Denmark, Finland. There, they didn't reveal any differences in approach of total neoadjuvant FOLFIRINOX to primary surgery. The same result without statistic differences. For now, this is not recommended as a standard approach to do neoadjuvant therapy. But this trial was criticized because compliance was almost 50% to pass all cycles of chemotherapy. Also, some interesting data. For example, the group was more beneficiary in a group of patients in a group of neoadjuvant treatment, in more radical and less with metastatic lymph nodes. Still, there is no beneficiary in long-term results. That means we have to wait for final analysis of this trial. We are waiting for another trial for neoadjuvant chemotherapy, upfront surgery with FOLFIRINOX after. This is also for the resectable pancreatic cancer, and we will see could they improve the previous trial. Finally, we have this cumulative data where we have some prominent trials based on the high quality of view of very high aggressive biology of pancreatic cancer. We have to understand, is it metastatic cancer before we do very damaging, very hard surgery and propose the surgery for our patients. That's why the diagnostic laparoscopy will be recommended at this ESCO in 2023. We also do, during this procedure, laparoscopic ultrasonic investigation, and from our data, it could change your strategy in 1/3 of cases. We sometimes found very small liver metastasis as well as tumor encasement in vascular wall. And even in this year, in 2024, for patient with a group of high expectation of distant metastasis, it start to be strongly recommended to do PET-CT from this year, 2024, in NCCN guidelines. I want to say a few words about new drugs. We have a very big expectation from them because this is only the one trial which is in next decade, in the last decade, shows some benefits in the treatment of metastatic pancreatic cancer, and we are waiting maybe to start trials based on the Onivyde in a regime like adjuvant or neoadjuvant treatment for resectable pancreatic cancer or borderline resectable pancreatic cancer, because the main problem still is tumor biology. Even the immunotherapy can break through this, and this is the drug which was accepted as by FDA as a new first-line treatment for pancreatic cancer, and we will ask the representatives maybe to give us opportunity to use it as a combined treatment with surgery. Also, back to the neoadjuvant surgery, there is some small trials for single metastatic pancreatic cancer where neoadjuvant approach could gives us the group of patients who will be beneficiary even to remove metastatic problems if it responds. I expect a lot of neoadjuvant approach which shows us a lot of benefits in other localization of GI cancers. That's why maybe new drugs gives us more and more advantages in this field. Thank you for your attention. And if will be the question, we're honored to answer it.
Thank you very much, Dr. Lukashenko. So we have one question from audience. Yeah, so.
Is there any chance to use methods of local, non-thermal probably, treatment like IRE or irreversible electroporation or electrochemoporation in case of non-resectable or local advanced disease without, of course, distal metastasis?
Okay, the RFA and such approaches to in palliative group for pancreatic cancer extensively used for pain control. First of all, I think we will we have today for palliative care. This is not influence on overall survivorship, of course, but maybe as a palliation, it could be because due to this anatomy and high dense of sympathetic plexuses in the region of pancreas, it's a still problem. Even we use some dosage for radiology to do palliation. I'm not ready to give you the data, but these types of approaches could be in a complex of palliative support.
And I would like to add that you talked about electroporation. So currently there is no enough data to talk if this method is so. As always, we need further trials to know whether it can be used or not for treating pancreatic cancer. Yeah, but the problem is that it was not published. Whether negative results or positive results, we don't have enough data to say whether it's effective or not. I would like to remind our listeners in the online that you can write your questions in the chat, so we can discuss it as well. And meanwhile, we will continue. And I think being a border between surgical treatment and systemic treatment, we have additional method to improve survival for patients with pancreatic cancer. And I would like to introduce our colleague from Chicago, who also works in Northwestern Memorial Hospital. It is Dr. John Hayes, who is radiation oncologist specialized in GI tumors in breast cancer and sarcomas. Unfortunately, he wasn't able to join us today online, but we will show you his recorded video. And I think with our colleagues and radiation oncologists, we will be able to discuss the question in the question part. So I would like to introduce Dr. John Hayes talking about topic of radiation therapy for treatment of pancreatic cancer.
Hello, my name is John Hayes. I'm a radiation oncologist here in Chicago, Illinois. I work at Northwestern University. I've been asked to review radiation therapy for pancreas cancer. And I'd like to do so today in about 25 minutes, tying together a number of concepts because the topics are extensive. We're going to walk through very little about adjuvant radiation therapy. I want to talk a little bit more about neoadjuvant treatment. I think in many sites in the GI tract, we've moved toward neoadjuvant therapy from adjuvant therapy. And that's for a number of reasons. They're site specific, we understand that. Yet I think it's important to make some of these analogies. We'll talk a little bit about primary radiation therapy. And nowadays, that means we're going to be talking about advanced technologies such as stereotactic body radiation therapy. And then lastly, just a little bit about palliative radiation therapy. Obviously, given the natural history of pancreas cancer, you could make an argument for an extensive discussion just about palliation. But in this discussion today, I'm going to tie it more into the advancements we've made in treating primary tumor and how they're growing and extending. Overall, there's about 495,000 cases in the world in 2020 and about 466,000 deaths. So in covering this topic, the requisite statistics, we need to remind ourselves that this is the 14th most common cancer worldwide and the 7th most frequent cause of cancer death. In the US, it's certainly not infrequent. We have almost 65,000 cases and again, 51,000 deaths. It's the 10th most common cancer, but it's now up to about 3% of all cancer deaths, and it is the 4th most common cancer death in both men and women here, and it's growing. Overall, its incidence is increasing by about 1% per year over the last 25 years or so. I tried to get a bit of a grasp on the problem there versus here, and what I came away with was these statistics showing me that it is just as frequently an issue and something obviously you all are prioritizing in treatment. Overall, we've made some progress, but as this graph shows from statistics in the UK, when you look here at the bottom, you've got some improvement, but it's still a relatively low ceiling. And in the US, this advocacy group has made a lot of the fact that its overall survival at 5 years has increased by a couple of percent in the last few years. And in that time, they've made a note of the fact that it's seldom been even a 1% per year, every couple of years improvement. So we see this as progress, yet obviously it's a daunting problem when you take care of patients with pancreas cancer. I want to start out speaking about adjuvant radiation therapy. And when I thought about this topic, I thought about the classic or the typical risk factors for local recurrence, because radiation therapy is a cooperative treatment here. I am here to complement resection. And we know there are risk factors for local recurrence from where the cancer arises, with the head and neck and uncinate locations having a greater risk of retroperitoneal recurrence in the body or tail. And we're specifically talking about local recurrence. The size of the tumor corresponds to that. Obviously, it's harder to do an embolic resection with larger tumors. Larger tumors also are going to abut unresectable anatomy, such as the vessels. Nodal status and margin status are both associated with increased local recurrences, as are lymphatic vascular invasion or perineural invasion. But with that being said, I don't want to get into this in any significant way because I simply don't think that the argument is going to have many buyers across the pond over there. And what I mean by this is if you look at recommendations today for patients who have had a resection and it's clear margin, in Europe, the recommendation is for chemotherapy alone. There is not a consideration of adjuvant radiation therapy. In the US, we've recognized that radiation therapy can improve local control. We feel that there is some value to that in terms of the quality of life for patients, maybe offering them as well time away from treatment. But it doesn't seem to have significantly changed overall survival if you look at the large group of pancreas cancer patients who have resection. And it doesn't change whether or not it's a margin negative resection or an R1 resection. And I found this, and quickly we'll go by it, but it's the idea that I can't find any adjuvant radiation therapy recommendations in the ESMO guidelines, which are about 6 months old now. Whereas in the US, they do allow, these are the guidelines from the National Comprehensive Cancer Network, a group of university hospitals here of which we're affiliated. And when you look at this, the clinical trial is the preferred approach in that setting. Chemotherapy alone is certainly acceptable, or chemo plus chemoradiation. So we're more open to it, but I don't think that it is a conclusion that it should be given, and I don't want to try and make that right now. I want to move towards discussing more neoadjuvant radiation therapy. How does radiation improve outcomes? And in February of 2020, in the Journal of Clinical Oncology, the pre-op PANC trial came out with almost 250 patients. And this trial approached things as saying, what if we give neoadjuvant chemoradiation therapy, then resect, and then also add adjuvant gemcitabine, and compare that with resection with adjuvant gemcitabine. So again, these are resectable and borderline resectable cases. The chemoradiation therapy was 36 gray or 2.4 gray times 15 with gemcitabine. Please don't get caught up in standard or hypofractionation comparisons. There's enough data to say that these are equivalent. And the result of this trial showed that there's no statistically significant difference in overall survival. And that was the primary endpoint. Radiotherapy did improve the R0 resection rates, and significantly so, from 40 to over 70%. And importantly, in the retrospective analysis, the borderline resectable cases showed improvement in progression-free survival and overall survival. So it wasn't necessarily a negative trial for that subgroup. Building from that, and because of those findings, pre-op PANC2 is ongoing. And I looked at this trial, and you see that the induction is going to be FOLFIRINOX prior to surgery versus gemcitabine and radiation therapy prior to surgery. Ideally, I would have liked to have seen FOLFIRINOX in both arms of this trial, but regardless, it's looking specifically at borderline resectable disease to see if we can improve outcomes. Again, similar regimens, and importantly, they're going to look at not only resection rate, progression-free survival, and quality of life, but they're going to look at some markers that will hopefully inform our decision-making as we go forward. Now, compare this to the Alliance trial, which came out in 2022. And again, specific for borderline resectable pancreas cancer, 8 cycles of modified FOLFIRINOX versus that 7 cycles plus radiation therapy. And then if there was no progression, they would attempt resection and add adjuvant FOLFOX. 70 patients were randomized, 16 following closure of arm 1. So this study met early closure criteria. The radiation therapy, very importantly, could be either stereotactic body radiation therapy, which is 5 fractions to 33 to 40 gray, or hypofractionated radiation of 5 gray for 5 fractions. And overall, what they found was the chemotherapy alone arm did better, and significantly so. Arm 1 had a 57% R0 resection rate, and arm 2, which was radiation therapy, was only 33%. Improvements in 18-month overall survival were correlated with that, and the median survival was significantly better. I admit, with these small numbers and with what seemed to be counterintuitive data, I have trouble accepting that radiation therapy wouldn't at least improve the R0 resection rate, as it almost consistently does elsewhere. So that's one reason we really haven't bought into the Alliance trial to a large extent, at least here, and I think in many other centers. Moving on to locally advanced pancreas cancer, very importantly, recognizing that the LAP07 trial, published in 2016, greatly influenced how folks in Europe treat locally advanced pancreas cancer, and it did influence how we treat it here as well, but I think, again, not as consistently. So it was an international open label phase 3 trial. It compared gemcitabine plus or minus erlotinib and chemotherapy plus or minus consolidation chemoradiation therapy. So there were 2 randomizations. There were 2 purposes to this trial. And they had 442 patients randomized first and 269 patients for the second randomization, with just over 100 in each of the second randomization arms. And they had 37 months of follow-up. The design is illustrated here for the sake of discussion. We'll go beyond this and just look for a moment at the results. The median survival in the chemotherapy and the chemoradiotherapy arms were comparable. There was no advance in survival because of the radiation therapy. Chemoradiation therapy was associated with decreased local progression. It was associated with more time off of treatment, but overall, this small difference here in the right-hand graph did not translate to improvements in the gold standard overall survival. So since that time, and as I showed earlier, radiation therapy is not typically included until it's needed. The questions for me that came out of this is local control unimportant as it relates to overall survival? Maybe it'll become more important with better systemic control. And maybe it's a combination of things. Could it be better local control being more meaningful if it's improved in addition to the systemic treatment improvements? So quickly, because this is a talk about radiation therapy, I do want to bring up that last point, because the PRODIGE 24 trial looked at almost 500 patients, and they found that modified FOLFIRINOX versus gemcitabine showed improvements for patients if they received the modified FOLFIRINOX. And that's also why I said earlier, I would have liked to have seen pre-op PANC2 include the FOLFIRINOX in both arms. But regardless, this was a significant treatment paradigm changing study. Quickly, when it comes to improving radiation therapy, stereotactic body radiation therapy is a mode of giving treatment that is nominally comparable if you look solely at the numbers of units of radiation, the number of gray or centigrade that's given. but it's very different in its radiobiologic effect. By giving 30 gray or 3000 centigrade in 5 fractions, you get an outcome, you get a difference in how it affects the target tissues as compared to somebody who gets that in 10 or 15 fractions. And all I wanted to illustrate here was simply that the cell survival curves reflect this. This is the basic cell model, cell death model of dose here versus the surviving fraction that informs this model or this paradigm of treatment. But in order to give radiation therapy much more densely, much more intensely, we also have to have accurate imaging. We have to have re-imaging at the time of treatment so that utilizing either CBCTs, that means cone beam CT scans, or MRI scans, that we're able to reproduce exactly what we've planned. And we have to make sure that we have motion management, ventilatory management, and gating of the radiation beam to the specific target. And again, these are discussions in and of themselves, but what these points are making is that these advancements in effect that we might get from very short course high dose radiation therapy, which is what SBRT is, they come from technical improvements that allow us to reproduce the plan and then monitor it in the course of treatment. The early studies on this really often cite the Stanford experience, which was a phase 1 report 15 years ago, where they used a single fraction, single dose of 2500 centigrade or 25 gray. They had a typical median survival of about 11 months. They found excellent local control with this. The problem was that they had late toxicity in a quarter of their patients, including gastric ulcers, duodenal and biliary stricture, and small bowel perforations. So they ratcheted back. They pulled back on the dose. And another influential study from 2015 was a phase 2 multi-institutional trial, limited number of patients from Dr. Herman and Associates, where 3,300 centigrade was given in 5 fractions. And they had excellent local control at 78%. The median overall survival had increased to 14 months. And importantly, segueing to more of the discussion, 8% of patients underwent resection. These were locally advanced cases, so resection wasn't really expected. This is a summary, it's a meta-analysis of standard fractionation chemoradiation therapy versus SBRT. And I just quickly want to point out that as SBRT has matured, 2-year overall survival has improved, grade 3 and 4 late toxicity has decreased significantly, and there's comparable grade 3 and 4 late toxicity. Here's a case that I used an MR-Linac for, and just quickly, this was an elderly gentleman, late 80s, who had disease centered here in the pancreas. And this real-time imaging allowed us to identify the duo adjacent bowel, and we're able to give, actually in his case, 5,000 centigrade in 5 fractions, which would give us a radiation biologic equivalent dose of somewhere in the neighborhood of over 10,000 centigrade. So the local control is excellent. And now we can also look at patients where we might be able to convert locally advanced disease to resectable disease. Remember how this came out of the earlier studies for SBRT. So this was a trial published in Acta Oncology in 2015 from Dr. Mellon and Associates, where they looked at almost 160 patients where treatment started with treatment was given, with FOLFIRINOX and SBRT. And they converted a quarter of their patients from locally advanced disease to R0 resections. And importantly, again, the late toxicity was only 7%. And in those patients who have resection, and resection is what is associated with long-term survival and potentially cure, it arose from 11 to 34 months. So how do we figure out who might get this advantage? And one of the things I think that is worth looking at is that as this disease requires a multidisciplinary approach, the folks at Johns Hopkins have published on how they approach locally advanced disease and whether or not they'll be able to or might expect to get enough reduction in the disease that they can undergo, the patient can undergo resection. So this study was an evaluation of how they approached this with a multidisciplinary determination of whether or not a locally advanced pancreas cancer was likely to undergo resection. That was LAPC1, unlikely was LAPC2, and very unlikely was LAPC3, so locally advanced pancreas cancer 3. So after induction, these patients had about a 10 to 50% chance that they would get an R0 resection. And so if you look at this, you'll be able to determine in cooperation, I think, with your surgeons, their particular technology, their expertise, which obviously weighs greatly into this, whether or not someone's likely to have a resection. Next, I'd like to talk briefly about palliation. We use radiation therapy and palliation routinely, and we approach it again depending on many factors. How advanced the disease is, what the patient's performance status is. And I'm speaking essentially site agnostic here, meaning that I'm talking about radiation therapy for palliation in general. We're moving more and more towards more aggressive palliation. And I think that one of the problems associated with locally advanced pancreas cancer that's very difficult to address is pain at the primary site. And we know that this is from invasion posteriorly into the celiac axis and the nerves there. And there's frustration in many of these cases that we're not able to control the pain, either with nerve blocks, with standard fraction radiation therapy, with hypofractionated regimens. So there is interest now, and we are moving forward with a trial here comparable to this. There's interest now in using more aggressive radiation therapy, at least in terms of the biologic dose. So I'm citing here a study that came out about 18 months ago from Israel. Dr. Hammer and associates had developed a protocol where they treated patients with a single fraction of 2500 centigrade in one fraction. And they targeted the celiac axis. They had 18 patients who initially had pain scores of at least 5 out of 10, and most were higher than that. And please note that these were not all just pancreas cancer patients, although 90% of them were. They looked at patients 3 weeks from treatment, and they found that 90% of those had their pain reduced from a median score of 6 down to 3. And at 6 weeks, there were further improvement in pain scores. And I thought noteworthy was the fact that 4 patients had complete pain relief. They also correlated this with decreased use of morphine. And just as importantly, the functional scores. How do patients feel? What's their quality of life? The pain interference score, and that decreased. So pain was less burdensome for those patients. So again, here, what we're looking at is utilizing more recent, as some say, more advanced technology, and selectively choosing when it might be helpful for the patients, separate from questions about overall survival. This is from that trial. I think it's worth noting or worth looking at quickly. What you see in the colors is how they defined the celiac axis, really looking at it, not the axis, I'm sorry, the celiac plexus, looking at it, how it overlays the vessels in the retroperitoneum between the celiac axis, the celiac vessel, and I believe about L1. So that is L1, L2. So that's your typical target. For this particular case, they're illustrating how they focused on the plexus alone. Please understand that the protocol allowed you to also add, I believe it was 15 gray in that single fraction, to the gross tumor overlying this area. So if this was a case of recurrence, you may not have that. But when the primary is intact for locally advanced disease, and I've treated patients with this approach, and the gross disease I've treated with an additional 15 gray. It's in continuity. You do it by dose painting. And the patients, a couple of patients that I've treated seem to have had very good benefits so far. So in summary, I look at pancreas cancer and the initial statistics and how there's ongoing advancements, and I wonder how they're going to be used. I think you look at yourself, you look at your teams, you decide really how you're going to utilize your resources, because that greatly affects it too. I mean, the optimist may want to throw everything at a patient, and the critics of that could say, well, you're providing false hope or you're wasting resources. And it's a slippery slope trying to be practical. On the other hand, if you get too pessimistic about things, you can be a fatalist and you can miss opportunities. And admittedly, you understand that there are going to be limitations. And I don't want to call them failures, but limitations. And right now, some of them seem like they're very low ceilings in how you're going to treat pancreas cancer patients. But remember, as we move forward, the goal is to use data-driven, evidence-based humility, understanding where each of us have limitations and trying to complement the other person. It's a team game. In summary, I'd like to say that for de novo resections, adjuvant radiation therapy is controversial at best, especially when you look at location. After R1 resection, I think that's more of a resource-dependent decision. As far as our radiation therapy and induction therapy, I think for borderline resectable disease, there's good evidence, and you can approach it in different ways: standard fractionation, hypofractionation, or SBRT. For locally advanced disease, you can give chemotherapy alone, and you certainly can defend that. I think it's very much worth considering consolidation radiation therapy, especially SBRT. You can provide better local control. There's accumulating data that this will be associated with improvements in overall or long-term survival, even if it's not curative. And some of our patients may be converted into having resectable disease. And we think that for them, we've opened a door to cure that wasn't there before. And lastly, SBRT is a developing strategy for palliative treatment, especially pain management in this disease. At the end, I like to summarize for most of my talks with this simple saying: selection is the silent partner of success. Thank you. Hello, my name is John Hayes. I'm a radiation oncologist.
Well, unfortunately, we don't have him alive to answer our questions, but I would like to summarize somehow. So performing of radiation treatment trials is extremely difficult, taking into account the lack of equipment and how difficult it to make the design of these trials. But meanwhile, we have this the role of radiation therapy in treating pancreatic cancer, especially as you could hear from the lecture that it is very important in borderline resectable cases and to make unresectable tumor resectable, and of course for patients who's suffering from pain, so it's very important for pain control. Do we have any questions from audience? Well, do we have radiation therapists? Well, talking about metastatic patient, today we will have a specialist in palliative care who will talk also. For today, the standard of care in United States, at least, is they do have only distant radiation therapy, but they also have this distant radiation therapy into the operation room. So during the surgery, while the patient is have the section, so the skin is opened, they do perform irradiation of surgery field after removing of primary tumor for resectable cases. So it's what performed, but unfortunately currently in Ukraine we don't have linear accelerators in our operation room, so we can't perform it right now. But I hope that in the future we will be able to do this. Okay, do we have our next speaker online? Great. So I would like to introduce you our next speaker. It is who is medical oncologist working in Dana-Farber Cancer Center, which is located in Boston, and it is Dr. Singh, who is specialist in GI tumors, but he is also specialist in basic science. So this is the in his patients. So I really welcome you today with us. I really thank you for joining us today. And so now we will hear talk about molecular targets and genetic subtypes of pancreatic cancer and methods of treatment using this knowledge for treating patients with pancreatic cancer.
Well, thank you very much for this very kind introduction and invitation. I just want to make sure you can see my screen, the full screen. Are we good?
Yes, we're fine. Thank you.
Perfect. Thank you. Well, a real privilege to join you today, and thank you for the invitation. My name is Harsh Singh. I'm a GI medical oncologist at Dana-Farber, and I mostly specialize in pancreatic cancer. And I was asked to talk about biologic subtypes and molecular targets in pancreatic cancer, which is really an evolving field. You know, just to give you context, if I was asked to talk about this topic 5 years ago, I would have said, man, I don't know what I'm going to talk about. And fast forward to today, when I heard this topic, I wasn't sure how I was able to cover this in a 25-minute talk. So there has been a lot of development, a lot of excitement around this, around therapies which are truly now working and helping patients. And I think a lot of basis of understanding these therapies is actually understanding the genomics of pancreatic cancer. So we'll start there. And then we'll go through some targets which are not an all-encompassing list of all targets in pancreas cancer, but I think the most important ones. So let's start with the genomics of pancreatic cancer. This is a study we did last year, but many studies have been published on this topic. This is genomics of pancreatic cancer in roughly 800 patients, both localized and advanced stage disease. For pancreatic cancer, the most important one being KRAS mutations, which are present in 90% of all patients with pancreatic cancer. Then it's P53, which is a master tumor suppressor that's lost in roughly 70% of patients, and then two more tumor suppressors, CDKN2A and SMAD4, which are lost anywhere between a quarter to a third of all patients with pancreatic cancer. And what we know is that within these core 4 alterations, they really drive the biology of this disease. This was first shown by Brian Wolpin here at Dana-Farber, but we recapitulated the same results in a much larger cohort, that the more core alterations you have, meaning restricting to whether you just have KRAS, KRAS P53, CDKN2A, or SMAD4, the more number of these core alterations you have, the worse is your overall survival, which you see in this Kaplan-Meier curve. So really, the genomics of pancreatic cancer really is the main driver of the biology of this disease. I also want to really emphasize how important KRAS is in this malignancy. So KRAS is an oncogene, which is turned on in 90% of pancreatic cancers, as we saw. It is also the first mutation to happen, which converts the normal pancreatic epithelium into pannin lesions. So it's the first alteration. It's present in every single cell of pancreatic cancer. It's a truncal alteration. And I think that'll be important as we think about how we're targeting KRAS now as a community. So normally, KRAS is a GTPase, which means it toggles between two forms, a GDP-bound form, which is inactive. And when it receives signals from extracellular growth signals conducted to it via receptor tyrosine kinases in the cell membrane, GAF proteins then exchange this GDP to a GTP, or guanine triphosphate, which turns it into an active form. It changes the shape of RAS so that now it can interact with downstream signaling pathways which it works through is MAP kinase pathway, which goes through RAF, MEK, and ERK, and then the PI3 kinase pathway, which goes through AKT and mTOR, as you see here. GAP proteins or guanine active hydrolysis proteins like neurofibromatosis type 1 protein NF1 will then cleave or hydrolyze the third phosphate, converting RAS GTP or on RAS into RAS GDP, which is the inactive form. So in response to extracellular signals, normal RAS protein toggles between an off and an on form, which is off form, which is GDP bound, and on form, which is GTP bound. 90% of pancreatic cancers, this RAS is altered or mutated in a way that now it starts living much more in the on state, which is GTP bound and hence signals downstream. We'll look at that a little bit more in the next slide. How important is KRAS to a pancreatic cancer cell? So they have these dependency maps where they take cancer cell lines or organoids and they knock out systematically the genes, different genes from those cells, seeing which, well, if we remove KRAS from the pancreatic cancer cell line or remove a gene, how much does it impact its ability to live? And so they've done that on the genome scale at the Broad Institute in this big effort called DepMap, where using CRISPR, they've knocked out single genes in multiple cancer cell lines. So this is data from pancreatic cancer cell lines. Again, showing that the impact of losing KRAS is immense. It's most highly significant gene, which is the first gene to be altered and leads to pancreatic cancer genesis. Even when pancreatic cancer develops, it continues to remain dependent on KRAS. So how does KRAS work? We've known that KRAS is an important oncogene for over 3 decades, but it's been really, really hard to target. And I'll cover why some of that has been. So here in a cartoon form is now shown RAS, which is in its GTP-bound on form in the right. And then GAP proteins or GTPase activating proteins hydrolyze this phosphate, as you can see here, and now it's GDP-bound form. And there is this 2 domains called switch 1 and switch 2, which interact with this third phosphate, changing the conformation of the RAS protein so that then in the on format, they can then interact with downstream regulators. So what happens when RAS is altered is that its ability to hydrolyze this GTP to go to GDP or off state is lost or is impaired. And hence it starts living much more in the on state. So that's how RAS mutations turn RAS on. So it's a switch which is broken, and now the machine. The next question is, well, why has it been so hard to target RAS as opposed to targeting kinases? So if we think about how we target kinases, an example being EGFR, kinases bind ATP, and GTPases bind GTP. And this is in a thematic manner how we would target a protein. We look for a drug which looks very similar to the ligand normally binding there. And then we sort of jam the antagonist or drug in place of the actual ligand. In case of kinases, it's ATP, and then hence lock the protein in an off state. The challenge is that GTPases, as you'll see here, bind GTP at picomolar affinity. So the affinity for GTP for a GTPase like KRAS is much, much higher than the affinity for ATP to bind a kinase like EGFR. And hence, for a molecule to outcompete a natural ligand in the cell becomes much, much harder. The other challenge, as you're seeing here, is that you kind of need some structural chemistry for the drug to fit into a crevice in the gene or protein you're trying to target. And RAS, I think about like a tennis ball, has like a very globular structure. So for a longest time, structural chemistry or chemists were not able to find a crevice in which, a drug could get lodged in or hook into the surface of KRAS for the purpose of inhibition. So between the high affinity it has for GTP and the lack of drug binding pockets on its surface was really responsible for it being so hard to target. Until there was a breakthrough. This is a seminal paper in Nature from Keyvan Shokat's lab, where they focused at a very specific mutation, so G12C, meaning at codon 12, the glycine is changed to cysteine. And cysteine is structurally important because it has this thiol group here. This is a very reactive group, so you can have a drug which can electrophilically attack this thiol group and form a covalent bond with the cysteine. So it now no longer depends on, hydrogen and other sort of non-covalent bonds to tag onto the molecule. It's linked or bound to the molecule with a covalent bond, and they were able to then find and then optimize parent complex mutated. And also, because it was now binding there, it was able to find a novel pocket, which is previously not seen, close to switch 2. And what this led to was KRAS being bound in an inactive GDP bound form. So this is an off inhibitor, meaning this binds to KRAS when it's off, when it's GDP bound. There has been a ton of structural chemistry, which led, just in the decade after this, where these drugs got optimized and have gone into patients now. But the concept for most of these drugs remains the same. They're covalent inhibitors, so they bind covalently to the cysteine. And by virtue of that, they're able to now find this novel crevice, which is mostly around the switch II region, blocking KRAS in an inactive form. So how relevant is G12C in pancreatic cancer? G12C mutations are most common in lung cancer. Roughly 15% of all lung cancers have it. Only 1% of pancreatic cancer has the G12C mutation. If you look at the spectrum of mutations, meaning the amino acid change, which leads to turning RAS on or KRAS on in pancreatic cancer, it's a little bit different compared to other tumors. The three major mutations are converting the glycine at the 12th position to either V, D, or R. And that becomes important as we think about how we're targeting this. 1% is a low number, but pancreas cancer is very common. So this allowed many drugs to be tested in patients who have G12C mutations in pancreatic cancer. This is some of the earliest data, which was published in the New England Journal by Dr. Strickler, data from a phase 1-2 study called CodeBreak 100, which is studying sotorasib, the G12C inhibitor from Amgen. They tested it in 38 patients who had refractory pancreatic cancer. Almost 80% of them had had 2 or more prior treatments. They really didn't have any standard of care options. And as you can see on the waterfall plot on the right, the response rate was 21%. So 30% or more shrinkage was seen in 21% patients who had refractory pancreatic cancer. The median progression-free survival was 4, as you can see on the spider plot up top above the waterfall plot, 6.9. Impressive numbers for patients who have refractory pancreatic cancer, who are otherwise will succumb to their illness in a matter of few weeks. We now have data from other G12C inhibitors in pancreatic cancer. So adagrasib is another off inhibitor or G12C off inhibitor from Mirati, which is approved in lung cancer. Again, in 21 patients, response rates are 33%. And then if you look at disease control, meaning not just patients who had a partial response, but patients who had some stable disease and derived some clinical benefit in addition to those who have partial response, you'll see that roughly these molecules, these G12C inhibitors, can control the disease in roughly 80% of patients. The PFS is variable depending on which molecule you look at. Glecarasib is another G12C inhibitor. The data was presented at GI ASCO in January. Here, the response rates look a little bit better, but I will just point out the numbers are low. And the patients who got treated with glecarasib perhaps did not have as refractory disease as was the case for patients who were treated with sotorasib and adagrasib. So hard to compare molecules to each other when they're not really done so in a randomized format. But the bottom line is that G12C inhibitors have activity in refractory pancreatic cancer when you target the G12C mutation present. So what's next for RAS inhibition in pancreatic cancer? I think of RAS inhibitors being developed in 3 broad buckets. So there are the mutant-specific inhibitors, as we just saw, the G12C inhibitors, which are already working. A few additional ones are listed here. There are a number of now specific inhibitors against G12D mutation. This is the most common mutation present in pancreatic cancer, roughly in 35% of all patients with pancreatic cancer. To an aspartic acid. And there are 3 drugs which are currently now in clinical trials, which are listed here. There's another class of drugs being developed, which will block not just a specific mutation, but all KRAS. So this is a parent compound, which is now in trials, which will block all KRAS mutations as well as wild-type KRAS. And the benefit there could be that when you have resistance to one mutation by another mutation emerging, you can perhaps overcome that because this drug will block every single mutation which can arise. There's a third class of drugs which is being developed, which I'm going to discuss in a little more detail, called pan-RAS inhibitors. So they not only block all RAS mutations, but they'll block normal KRAS, NRAS, and HRAS. And that drug's a very interesting molecule called RMC-6236. The initial concern here was that this would be too toxic because you're completely blocking RAS signaling, not just in cancer cells, but also in normal cells. But the results, the clinical results have been very interesting. So let's look at this drug. It's a novel class of drugs which works with this molecular glue mechanism, which means it's an oral medication, you take it. The first thing it does is it binds cyclophilin A and forms a binary complex. And it changes the surface of cyclophilin A now that it can bind with RAS. And it binds RAS in the on form, meaning when RAS is bound to GTP. And hence, because it binds it, RAS can no longer interact with its downstream mediators like RAF proteins or PI3 kinase, and hence it blocks RAS signaling. This is results which are presented at ESMO. So it was a standard dose escalation design of this oral medication in patients who had refractory lung cancer and pancreatic cancer. I'm showing results for pancreatic cancer patients. 46 patients were treated. I don't need to say much more. You can look at the waterfall plot. It's very impressive. These are refractory patients, again, a response rate of 20%. But even more impressive is that almost all patients, 90% or so patients, have had some shrinkage of disease and control. And you can look at the number of arrows we're seeing. These are all patients who are still undergoing and are still on this drug. So, early data, but at least we see very good initial disease control in a majority of patients who get this drug. Are high patients, they're chemo resistant. So these are very, very impressive results. This is, again, the spider plot, again, highlighting, again, that most patients are still on therapy. So we don't actually know how long this will work for. That data will mature over time. What we do know, and that's consistent between other KRAS G12C inhibitors and other oncogenic inhibitors, is that when you block an oncogene like KRAS, you respond quickly. So the median time to response is 1.4 months. So that's fairly quick. So this is a really exciting drug for pancreatic cancer. It also covers most of the major G12 mutations. So roughly 80% of the mutations in pancreatic cancer have a G12 change. So the glycine at codon 12 is changing to VDR. And this would be applicable for all of those patients. So it has broad applicability. It seems reasonably well tolerated. It has some rash and nausea and diarrhea, but they're reasonably easy to manage. And so an extremely exciting drug, which almost certainly will be developed further in pancreas cancer. We'll switch a little bit in other ways of targeting mutant KRAS. And one of the exciting mechanisms is how can you target mutant KRAS in an immunological manner? And so how does the immune system recognize mutant KRAS? So this is an MHC molecule, which is present on every cell, and it presents intracellular peptides. It processes proteins into peptides and then presents them for the immune system for the T. If the mutation points upward toward the T cell receptor, the T cell can recognize that as something different from the wild type protein. And several studies have shown that many of the KRAS mutations are presented on different HLA haplotypes, so that mutant KRAS can be presented on HLAs and can be recognized as immunogenic. The table is just to show you that it's been done for several haplotypes and several mutations, not necessarily to be read. But that is a way the immune system can recognize mutant KRAS. And it's been used therapeutically in a couple of different ways. This is a New England Journal case report from a couple of years ago, work done by Eric Tran. So here they had identified a T cell which recognized KRAS G12D mutations when they were presented on HLA-C, a haplotype HLA-C. It took a cancer who had the G12D mutation and the recognizable or the defined haplotype, the HLA-C haplotype, and then they transduced their T cells, the patient's T cells, with this unique T cell receptor known to bind mutant KRAS. And when they did that and infused this as a TCR-T-based cell therapy, they saw prolonged disease control in the metastatic sites for over 6 months. In addition, they could see that the cells which they had transfused, these engineered T cells, they showed long-term persistence up to 6 months in the patient's blood. So again, just a case report, but this has led to, ushered in an era of a lot of TCR therapies being driven in trials now against KRAS and being tested in pancreatic cancer. There's one other strategy which has been used, or which is being used, is to immunize patients with mutant KRAS peptides or mutant KRAS. so that they can invigorate an immune response, a T-cell immune response, to try and target KRAS. This is a figure here of one of the peptide-based vaccines. Suffice it to say that there are novel vaccination strategies, and this has been tried for over 30 years to try and vaccinate people against KRAS, but now there seems to have been a change in enthusiasm again, because these novel vaccination strategies are highly immunogenic in people. And hence, because they can T-cell response, people are again super excited about their potential therapeutic efficacy. Vaccines are generally tested in patients who have resected disease. So I'll show you some data from the peptide vaccine, which was on this slide. It's a very unique peptide vaccine, but to test its efficacy, they looked in a phase 1/2 trial in patients who either had resected pancreas cancer or colon cancer. The two mutations which this vaccine covered were G12D and G12R. And they needed to have no evidence of disease, but needed to have a positive biomarker. That means either positive by circulating tumor DNA or elevated circulating tumor markers such as CE or CA19-9. So these are patients who had no evidence of disease, but they really were at high risk of the cancer coming back given the biomarker elevation. This is a waterfall plot after vaccination for these KRAS peptides, with these KRAS peptides, showing that in many patients, they saw dramatic reduction and even clearance of the biomarker, which means the biomarker was completely cleared from their system. What they also showed was that when they measured how much of a T-cell response or an immune response was generated by the vaccine, patients who had more of an immune response lived longer. So now this has been incredibly exciting. This was published in Nature Medicine. This study has now gone on to a randomized phase 2 study where patients will be randomized after resection to either get the vaccine or not. And the primary endpoint will be recurrence-free survival. So really now trying to ask, we know these are immunogenic, but can those T cells, which are now anti-KRAS, find the remaining cancer cells? And can those patients now either relapse late or live longer? So again, we're going to learn a lot more about KRAS vaccination here. And about KRAS inhibition summary in pancreas cancer. So G12C inhibition is clearly clinically active in patients with advanced pancreas cancer. This has held up long-lived preclinical predictions. However, the response rates and duration of response are lower and something which needs to be improved. Pan-RAS inhibitor RMC-6236 is showing encouraging clinical activity and can significantly impact and improve survival for patients with pancreatic cancer. There are several new allele-specific inhibitors, pan-KRAS and pan-RAS inhibitors, which are in preclinical and clinical development in early stage clinical trials, which are looking really promising. KRAS targeting by the immune system, either by TCR-T-based therapy or vaccinations, are really interesting and novel ways which are now going to be investigated in more detail. And I think this has generated many more questions than we can answer at this moment. What's the best way of doing it? Is it single agent? Is it combination? If you have a G12C inhibitor or mutation, is it better to target it with an allele-specific inhibitor or a pan-RAS inhibitor? And what are the mechanisms by which cancer cells may become resistant, and what are therapeutic strategies to overcome these? So this is going to be a very active area of translational research in years to come. I'll switch gears, talk briefly about KRAS wild-type pancreatic cancer. So I said 90% of pancreatic cancers have a KRAS mutation, 10% do not have a KRAS mutation. If you study the genomics of these, roughly 40% of them are what we call MAP kinase mutant, which means they have additional alterations which are oncogenic and driving those. If we look at what those mutations are, if we collate this across a couple of different studies, 15 to 25% of these patients will have a BRAF mutation, which is oncogenic. 10 to 20% will have oncogenic amplifications. So for example, for BRAF, the most important and most common change in pancreatic cancer is actually different than what's found in melanoma. It's an in-frame deletion, which turns BRAF signaling on in a completely different manner than what V600E does. And because of that, this is generally resistant to treatment with dabrafenib or vemurafenib. What we have shown and others have shown is that they still remain susceptible to pan-RAF inhibitors, so that could be considered on a clinical trial. V600E is less common, but it's present. When it's present, dabrafenib and trametinib certainly has a role in treating these patients. Fusions can be found in a variety of different proteins, several of them more enriched in pancreas than in other tumors. The key here is that the nature of a fusion is such that one gene breaks and it joins to another gene. And depending on the kind of DNA-based next-generation sequencing these can be missed. So if you see a patient who has a KRAS wild-type pancreatic cancer without a driver on DNA-based NGS testing, certainly would recommend RNA-based testing, which there are a variety of different platforms which look at the fused transcript by RNA and can pick up fusions which may have been missed. And they certainly present therapeutic opportunities, which are listed here. So NTRK fusions have a histology-agnostic approval for entrectinib and larotrectinib. There are several FGFR2 inhibitors which are working well in FGFR2 fusions. Selpercatinib is approved in a histology-agnostic manner for RET. ROS, ALK, again, we know these inhibitors. BRAF, again, point about BRAF fusions, again, dabrafenib and vemurafenib do not have activity. And then there's a new kid on the block, a new bispecific antibody called zenocutuzumab, which blocks NRG1 fusions. I had more information here on this, but in the interest of time, I'll skip forward and talk about a couple of different topics before I wrap up. So moving away from MAP kinase targeting in a combination deficient pancreatic cancer. So DNA damage has many repair pathways. When there are double-strand breaks, the cell relies on homologous recombination to repair a double-strand DNA break. These include genes like BRCA1, 2, and PALB2. And these mutations, often called core homologous recombination mutations, are present in 7 to 10% of all patients with pancreatic cancer. When you have any of these mutations, your core HR or your homologous recombinase deficient, you become very sensitive to platinum-cased chemotherapy, and that's because you cannot repair double-strand breaks, and platinum promotes DNA intercalation and double-strand breaks. So this is retrospective data shown on the left, where patients with germline BRCA1 or 2 actually do not respond better to platinums. And then a clinical trial done by Dr. Eileen O'Reilly looking at gemcitabine and cisplatin with or without a PARP inhibitor, but really showing the PARP inhibitor in this study was really not as important, but really showing that in patients with germline BRCA1, 2, or PALB2 mutations, GemCis has a very impressive response rate of 65%. In pancreas cancer without HR mutations, GemCis really is not that much better than gemcitabine monotherapy. So these results are really active and point to the fact that these cancers are very platinum sensitive. Similarly, they become very sensitive to PARP inhibition. So PARP is generally involved in base excision repair, which is a single-strand break. If you block PARP, a single-strand break now gets converted into a double-strand break. And because you're HR defective or HR deficient, the cells die because they can't repair a double-stranded break. And that concept is called synthetic lethality. So PARP inhibitors were working in ovarian cancer and breast cancer, and that led to the POLO trial, which was a randomized phase 3 double-blind trial where patients who had germline BRCA1 or 2 had disease control on first-line platinum-containing chemotherapy for at least 16 weeks were randomized to either receive olaparib or placebo with the primary endpoint of PFS. PFS from 3.8 months to 7.4 months. This was a New England Journal paper, and they received FDA approval. The surprising thing was there was no survival benefit. The median survival was 19 months approximately in both the arms. And this has led to a lot of discussion of why this was. Perhaps not as important for this talk, but there was some crossover. And then as you keep going out towards the tail of the curve, the numbers do tend to separate out. It does seem like there are patients who are on PARP inhibitors who are definitely, deriving much more benefit, but it's a minority of patients who derive this really long-term benefit from PARP inhibitors. This has now led to another trial, which Dr. Kim Rice is running from the University of Pennsylvania called the Apollo study. So now they're taking patients who have BRCA or PALB2 deficient tumors, which are localized. After they've had all their surgery and chemotherapy treatment, they'll be randomized to receiving either olaparib or placebo, really trying to see, can we cure now these patients more by giving them PARP inhibitors after they've had standard local therapy. So this is a really interesting trial, which is ongoing. I'll skip some of this part in the interest of time. And then I'll talk a little bit about what's the future of HRD deficient pancreas cancer. One is we need to improve biomarkers of response. As was clear from the POLO trial, PARP inhibitors don't help every patient, and there are some patients who are intrinsically resistant. There's a lot of work ongoing. Can we derive mutational signatures, which may help us identify patients who will benefit from PARP inhibitors more? Novel PARP inhibitors are being studied and by themselves and then in combination with immunotherapy. And then we're expanding this to other DNA damage gene alterations, including ATM loss, which is present in roughly 5% of all patients with pancreas cancer. Very briefly, there's another kind of repair called mismatch repair, and roughly 1% of pancreatic cancers are mismatch repair deficient. This is a unique and different mechanism from colon cancer, where it's related. Patients have a mismatch repair deficiency, either have Lynch syndrome or they have somatic MMR gene mutations. And we diagnose this typically either with immunohistochemistry or next-gen sequencing, where these tumors have high tumor mutational burdens and you can find mutational signatures. And the bottom line is that these tumors, because of their high tumor mutational burden, are responsive to checkpoints like PD-1 or PD-1 with CTLA-4. And it's a small percentage, but if you don't look for these patients, we'll never find them. So in summary, we talked a lot about MAP kinase targeting. Do not forget the 10% of patients who have KRAS wild-type pancreas cancer, which have other targetable alterations. There are a number of now G12C inhibitors which have clinical activity in pancreatic cancer, which is G12C mutant, although that's only 1% of patients. There are a number of G12D specific inhibitors in clinical trials. The pan-RAS inhibitor trial data looks very promising, even though it's early. And then there are a number of new KRAS targeted agents which are coming down the pike. And then in the DNA repair pathway, if you have a core homologous recombination defect, meaning you have a germline or somatic BRCA1, 2, or PALB2 loss, which is roughly 5 to 7% of all patients, PARP inhibitor maintenance is approved after first-line therapy, but it doesn't help everybody. We need to optimize these responses. Roughly 1% of patients are mismatch repair deficient, and immune checkpoints like PD-1 and CTLA-4 are quite effective there. And I think beyond that, looking to the future, roughly 15 to 20% of patients have other mutations in other DNA damage and homologous recombination genes like ATM and CHEK2. And we don't quite know how best to treat them with targeted therapy, although that remains an area of a lot of interest and work which is ongoing at many different centers. So hopefully in the end, I was able to at least share with you a little bit of my excitement around the what I think is an era for novel therapeutics and improving outcomes for patients with pancreatic cancer. We're finally seeing drugs which are actually working in people. And I think this is the result of collaboration and effort of decades of research and clinical effort, which we're now seeing the fruits of. So I'll stop there and happy to take questions.
For such an interesting report. Do we have any questions from audience? Because me myself, I have plenty of questions when we're talking about the new targets, and it is always very, very interesting and discussable topic. But we're lacking of time, so I'll just ask 2 questions regarding topic you covered. And the first one is about KRAS G12C inhibitors. So we saw that actually progression-free survival time and overall survival time was not very, very good. So progression-free survival, median progression-free survival was just 4 months. But we also saw that really small part of patients were responders, so there were only 20%. So was there any sub-analysis of this group of patients who were responders? And do you know how long they lived, how long their progression-free survival was?
Yeah, that's a great. G12C inhibitors, although they're working, they don't work forever, and they certainly are not helping everybody. And I think that 2 things come to mind. One is that the duration of response is roughly 5 to 6 months. We have to keep in mind that these are refractory patients. Their cancers are very, very aggressive. And so one of the thoughts in the field is, can we move these inhibitors to earlier lines of therapy, where essentially every cancer therapy works better in earlier lines. There's a lot of really interesting work also going on around mechanisms of resistance. So there was a paper showing that very quickly into treatment in the New England Journal by my colleague Andy Aguirre, where they showed that very quickly into treatment, you can actually develop a lot of putative resistance mutations in other MAP kinase genes, including other RAS mutations. So if you develop those, then this drug doesn't bind there, and whether pan-RAS inhibitors would work there would be something. There are other different kinds of different kinds of RAS. So these G12C inhibitors we have right now are G12 are block the off form of KRAS, so they're KRAS off inhibitors. There is some data in lung cancer that newer inhibitors which block the GTP bound form of KRAS G12C seem to be more effective and may be effective even in cases who've had resistance. So a few thoughts: move them early into therapy, neo-RAS inhibitors, and then potentially think about, do we need to combine them or follow them once they have resistance with a pan-RAS inhibitor? But there are many, many other things which can be thought about. There's all these potential combinations with chemotherapy people are thinking about also. So this is perhaps the most active area of translational research in pancreatic cancer right now, thinking about RAS inhibitor resistance and how to overcome it, how to do better.
Interesting talk on the topic, and we are moving forward for our next lecture. And I would like to present Dr. David Ryan, who is head of Department of Clinical Oncology in Massachusetts General Hospital, which is located in Boston. And he will talk on the topic of systemic therapy for pancreatic cancer.
Hi, my name is Dr. David Ryan, and I would like to thank Dr. Veronica Patsko for the invitation to talk to your great society. We had the pleasure of hosting Dr. Patsko as a visiting oncologist at Massachusetts General Hospital in Boston this last year, and it was really a delightful experience, and we loved having her in clinic. So she asked me to give you today a talk on pancreatic cancer. And so what I'd like to talk to you today about is our approach to those patients with localized disease. And I'm going to share my screen with you. So I am the Chief of Hematology Oncology at Massachusetts General Hospital, and I am also the Clinical Director of the MGH Cancer Center. And we are a big believer in total neoadjuvant therapy for pancreatic cancer in 2024, and I want to share with you why. So as you all know, the cancer statistics for the United States just came out in CA, a cancer journal for clinicians, and pancreatic cancer is now the third leading cause of death for women and the fourth leading cause of death for men. You can see that we expect over 50,000 people each year to die of pancreatic cancer and about 65,000 people to get pancreatic cancer. So we are improving somewhat over the last several years, and we fully expect, though, unfortunately, that pancreatic cancer will remain a very high percentage of cancer-related deaths in the United States and really throughout the developed world. You can see here pancreatic cancer trend line since the 1930s really hasn't changed much. It's the orange line. Compared to every other cancer, pancreatic cancer for both men and women has stayed relatively stable, suggesting that it's not necessarily something in our environment. It's just a feature of the turnover rate, natural mutation rate in pancreatic tissue. A couple of things just to note. I won't get too much into chemotherapy specifics, but I will like to point out that about 10% of patients will have a genetic predisposition to pancreatic cancer, and about 10% of patients will have a BRCA or PALB2 or BRCA-like mutant tumor when you combine both somatic and germline. Germline representing about half of that, about 5%, and another 5% somatic mutations. The reason why that's important is that the BRCA-like tumors may respond better to platinum-based chemotherapy, and obviously they can respond to PARP inhibitors as well. NCCN now recommends that all patients with pancreatic adenocarcinoma get BRCA testing. So the modern era of pancreatic cancer begins with the Conroy study comparing FOLFIRINOX to gemcitabine. And finally, with FOLFIRINOX, we had real responses and a real improvement in survival getting the average patient almost a year of survival compared to the historic days of gemcitabine or 5-FU alone. Gemcitabine and Abraxane can work, but probably not as well as FOLFIRINOX. It may be due in part to the BRCA story that is emerging, but there's also a sense that FOLFIRINOX probably is just a better all-around anti-cancer therapy for pancreatic cancer. There's not a lot in terms of second line. There is, of course, FOLFOX for those people who had gemcitabine, and there's the NAPOLI-1 study looking at 5-FU and liposomal irinotecan. The breakthroughs in pancreatic cancer are coming slowly. There are some breakthroughs coming with KRAS targeted therapy and potentially with cellular therapy and antibody drug conjugates, but those are still several years away from clinic. One of the things that we have seen over the years is that pancreatic cancer resection has become much, much safer. This is a not too distant, about 10 years old survey of pancreatic cancer mortality from surgery. And a Whipple generally is associated in the United States with a 5.9% mortality. Most major centers, though, are down to 1 to 2%, and we expect 1 to 2%. I think one of the difficult things about pancreatic cancer is that these cancers really should be resected in a regionalized center that does this all the time. It's not just about the surgeon or surgeons. Sometimes help is needed in the OR, and so you need multiple surgeons, often vascular surgeons who can repair torn vessels. But it's also about the post-operative recovery, the intensive care unit, the nursing, the interventional radiology that can place drains, the help of infectious disease doctors even. So it's really a team approach that at the major centers gets mortality down to the 1 to 2% range. And there's an emerging difference between centers that routinely take patients to the operating room versus those that do not after total preoperative therapy. Some believe in it, and some don't. And the ability to manage complications after total neoadjuvant therapy is of paramount importance. And anecdotally, what we found is some centers just don't have the ability to manage them and therefore avoid total neoadjuvant therapy. Adjuvant therapy for pancreatic cancer has been coming now for quite some time. Multi-agent chemotherapy is better than single-agent chemotherapy. And the modern era, of course, starts with the PRODIGE study, which randomized 493 patients postoperatively to gemcitabine versus modified FOLFIRINOX. Couple of things to point out. Number one, these are very healthy patients, young patients as well. So the majority of patients were under the age of 70. The second thing to point out is that this is an alarming rate of R1 resection. Now, nearly half of patients undergoing treatment, 40% in this series, had an R1 resection. I'm going to come back to that point. And then a very high percentage of patients had no positive disease. Why do I point this out? Because to cure someone's basic principles of solid tumor oncology require us to get an R0 resection. And we know that the amount of lymph nodes that are positive alter the prognosis, and reducing the incidence of an R1 resection and creating pathologic responses that are node negative are often associated in multiple other settings, including gastrointestinal cancers with improved overall survival. So here, the adjuvant therapy with FOLFIRINOX did improve survival by a significant amount with a hazard ratio of 0.58, and this became the standard of care from then on. And giving postoperative FOLFIRINOX, though, can sometimes be quite difficult, and anecdotally, I can tell you that it's much easier to give preoperatively. The other thing is that not everybody is a candidate for chemotherapy postoperatively. Multiple series have demonstrated that only about 75 to 80% of patients are candidates for adjuvant chemotherapy after pancreatic cancer surgery. Let's look here at the patterns of recurrence. This was published just last year in JAMA. And you can see that the effect of FOLFIRINOX is not on local regional control. The effect is on systemic control of disease. Metastasis as a first event was significantly reduced in the FOLFIRINOX group, which then led to the overall survival. The local regional recurrence rate was essentially the same, 21% and 22% in each arm. And so local regional recurrence remains an extraordinarily high rate of occurrence after pancreatic cancer surgery, something that we wouldn't tolerate, I think, in most other gastrointestinal cancers. And so what can reduce that? Well, obviously, you know my bias here, it's radiation therapy. The other thing to point out is that adjuvant gemcitabine and nab-paclitaxel did not improve upon survival the way that adjuvant FOLFIRINOX did. You can see here both the disease-free and overall survival endpoints. The overall survival endpoint did fall beneath 0.045, but it's unclear how that happened when disease-free survival was exactly the same. And so this did not meet the primary endpoint, which was disease-free survival of this particular randomized study. And so there's an emerging great divide happening in the world, and that is those who believe in total neoadjuvant therapy and those who don't take people straight to the operating room. And if you don't take people straight to the operating room and think that someone is either too locally advanced to resect, many people are just going with ablative doses of radiation therapy and never taking those patients back to the operating room. So I'm going to come back to this point of R1 resection. So 40% in the FOLFIRINOX study. Here, the SPAC4 study, it was 60%. What other solid tumor do we take to the operating room as initial management, knowing that 60% of patients will have an R1 resection? It's my argument today that preoperative imaging is not good enough to determine whether you're going to have a successful R0 resection. R0 resection is the sine qua non of cure in those patients with pancreatic cancer, I'm going to argue, and I think really in solid tumor oncology in general. And we have moved for some reason in pancreatic cancer to a position of accepting an enormously high rate of R1 resections. And I don't think we would accept that in any other gastrointestinal cancer, much less any other solid tumor. And why is this important? Well, this is the Iacobuzio series from the JCO in 2009 at Hopkins, and they looked at how do patients die from pancreatic cancer. And she looked at 76 autopsy series. 12% had no metastatic disease, and 30% had minimal metastatic disease and actually died from local disease. Local control is incredibly important in pancreatic cancer, and I think that we have not paid enough attention to local control. Many patients will wind up dying from local progression, and if they don't actually they don't actually die from metastatic systemic disease, but they actually die from the complications of local disease. What I can tell you from anecdotal experience from patients in the hospital, those patients who actually had resection and recur wind up living a lot longer. They have lung metastases or liver metastases that often can be controlled in the absence of dealing with biliary stent issues, cholangitis, duodenal obstruction, et cetera, and not to mention bleeding. So in my mind, we have this false narrative of dividing people into resectable, borderline resectable, and locally advanced disease. Does it really matter? Does it really matter if I'm going to treat everybody with total neoadjuvant therapy? And that's my current position. I think everybody should be treated with total neoadjuvant therapy. Why? Well, the potential benefits. It's better tolerated when you give it all up front. Giving postoperative FOLFIRINOX is difficult, and it ensures the delivery of that chemotherapy that we know reduces the risk of metastatic disease. 20–25% of patients will never get any adjuvant therapy after a pancreatic cancer surgery. We know that it facilitates R0 resection. It's not may facilitate, it actually does facilitate R0 resection. And as a believer in local control, we know that radiation is better tolerated preoperatively than postoperatively. All you have to do is look at the images of dosing radiation preoperatively than postoperatively to understand that a postoperative dosing encompasses a much wider field and is much more toxic than preoperative dosing of radiation therapy. Why did we come to this conclusion? Well, we were running 4 clinical trials in succession and also concurrently, 2 in resectable patient population and 2 in borderline and locally advanced patients. The borderline and locally advanced had the same backbone of FOLFIRINOX for 8 cycles, followed by individualized chemoradiation. Some got short course, most got long course chemoradiation. And what we were experiencing is that the people who had short course radiation at this time and going directly to the operating room, as was the case in our resectable patients, were doing worse than the people who were getting FOLFIRINOX. And we started to say, oh my goodness, why is this happening? So we then looked at our MGH series of locally advanced and borderline resectable taken to the operating room. And this was not prospective series, but we found that resection was key to cure, that if you really wanted long-term survival, resection was key. And here's our survival either from the time of diagnosis or the time of resection. And the other thing that this pointed out to us is that post-total neoadjuvant therapy imaging is not predictive of resection. It was very difficult to predict who was going to be resected and who wasn't. In fact, you had to take everybody back to the operating room to figure out who is going to be resected versus who is not going to be resected. And so we then looked at our prospective series, and among patients resected with borderline, our PFS was 48 months and our 2-year overall survival was 72%. Figures that I never thought we would see when I was first an oncologist. For our locally advanced patients, among resected patients, 21-month PFS and a 33-month overall survival. That was exceeding what we were seeing in resectable patients. This is locally advanced patients. And so my daughter, actually, when she was working with us before going to medical school, put together our experience of combined in our locally advanced and borderline resectable protocols of long-term follow-up. 61 patients of the 90 patients who completed therapy and 80 who were taken to the operating room, 61 patients had an R0 resection and 5 patients had an R1 resection. And you can see here that 23 of the 23 of the 66 patients who had an R0 or an R1 resection were alive, free from progression, and were considered NED, compared to 3 of the 31 who didn't undergo resection and underwent instead intraoperative radiation therapy. And so if you want a chance at cure, you have to resect these patients. Now, what has thrown a curveball in all of this? Well, the Alliance study decided to look at FOLFIRINOX as preoperative therapy, either followed by surgery or followed by SBRT and then surgery. And what they found was that in this patient population, they closed it early because one of the arms was doing poorly. But one of the things I want to point out to you is how difficult it is to manage these patients through the perioperative experience. And 50 sites accrued only 1 or more patients, right? So these are multiple sites who don't have experience with doing total neoadjuvant therapy. And what did they find? Well, they found that in arm B, which was the chemoradiation arm, the radiation arm, followed by which was followed after chemotherapy, only 10 patients completed therapy compared to 20 in the chemotherapy alone arm, and that they had a significant increase in perioperative complications. If you're not used to doing this, you're going to run into trouble, and it's going to be difficult, and people are going to wind up not doing well because of perioperative complications. The other thing is that we really need to reevaluate SBRT in the adjuvant setting. It may not be the right way to deliver radiation as opposed to long course chemoradiation. And what they found was that the survival and the resection rate was worse in the patients who were undergoing radiation therapy. So they said it didn't meet criteria and they stopped the study. Well, I think, unfortunately, this put a damper on neoadjuvant therapy and total neoadjuvant therapy. So what data do we have? Well, we have the PREOPANC study and the Korean study. And the PREOPANC study, this is in the era of gemcitabine, randomized people to neoadjuvant gemcitabine followed by gemcitabine radiation versus going directly to surgery followed by gemcitabine. And you can see here that the median DFS was significantly better in the preoperative chemoradiation arm, and the R0 resection rate, importantly, the R0 resection rate was statistically significantly better, a 51 of 72 versus 37 of 92, so 40% versus 70% versus those undergoing preoperative chemoradiation versus direct to resection. And this translated into survival benefit. Overall survival, disease-free survival, local regional control. So local regional control, and this is metastatic disease. It's really about local regional control. When you're adding radiation, you're adding local regional control. And the impact is quite remarkable when you look at this, the long-term impact on local regional control versus distant metastatic failure rate. And this is the published update in ASCO 2021, where overall survival then was 20% versus 6%. And I will argue that it's about that R0 resection rate, and getting an adequate R0 resection rate is critical for long-term survival and cure. And you can see here that the long-term survival, which was subsequently published in the JCO last year, definitely looks better for the neoadjuvant therapy group. And it looks better in both the resectable upfront and the borderline resectable patient populations as well. The key point, though, is that when you look at just the patients who undergo resection, the magnitude of difference in overall survival is quite large. And remember that it's hard to do these randomized controlled studies where there's such a difference in centers about the ability to resect and to make the decision to go after that resection, even though something may look locally advanced on imaging. So the inclusion of borderline and upfront together was a criticism of this study, but nonetheless, it was a positive trial, and it wasn't a FOLFIRINOX-based chemotherapy. And so this was just in gemcitabine. And so the ability to deliver preoperative radiation, I think, has a significant impact on local regional control and therefore survival. The Korean study similarly randomized patients to chemoradiation followed by surgery and then adjuvant gemcitabine, or surgery followed by chemoradiation and then adjuvant gemcitabine. And you can see here that the 2-year survival was statistically significant in the neoadjuvant group. And the R0 resection rate was doubled. So the R0 resection rate went from 26% to 51%. I think it's all about the R0 resection rate. So an approach to localized pancreatic cancer that we have is that an R0, N0 resection rate is the means to long-term survival. Preoperative imaging poorly predicts R0, N0 resection. And total neoadjuvant therapy gives patients the best chance for R0, N0 resection. Surgical exploration, even in the face of vessel involvement on imaging post-TNT, is critically important. You can't just assume that that's a tumor that's up against the SMA or SMV. It may, in fact, be scar tissue and fibrosis. And long-term survival is most often associated with R0 and N0 resections. So our current approach is we start with FOLFIRINOX, we assess after 2 months, and then we do another 2 months of FOLFIRINOX. If after 4 months no progression, we administer standard 5-FU either by IV or capecitabine with long course radiation. And then we do a surgical consult after completing the chemoradiation, and we really ask our surgeons to push the envelope and take those patients to the operating room for potential Whipple. Future directions, I just want you to be aware that BRCA-positive patients may respond better to platinum-based therapy and respond in the adjuvant setting to a PARP inhibitor. Keep your eyes open for data like that. MSI high positivity occurs in 1%. You have to look. It's not a lot. We've all been burned, though, with a patient who didn't have a great response to chemotherapy, thought they needed to go on hospice, but then somebody smartly looked for mismatch repair proteins. And when they're absent, those patients can have incredible responses to checkpoint inhibition. And that we think that preoperative therapy for localized disease should be the new standard of care. I want to thank you. This has been a delight. I wish you guys all the best in the Ukraine, and you have a wonderful doctor in Dr. Patsko. She's just a tremendous asset good luck to you all.
Able to join us for a question session. And does anyone have any questions regarding systemic therapy of pancreatic cancer? Well, we did hear that, well, team approach is actually a key for a successful treatment, and we also heard that the most important in treatment of pancreatic cancer is surgery, which performed with high quality and reaching R0 resection. And I would like to follow to our next topic. Unfortunately, pancreatic cancer is that type of malignant tumor which very often diagnosed on the late stages, like locally advanced or metastatic disease. And this patient, unfortunately, very often don't have an opportunity to receive any kind of treatment. Doesn't matter whether it's surgery or systemic therapy. So this patient require really big support from our colleagues from palliative care, but I also like to admit that palliative care unit is not only about ending life of patients, so these colleagues are very important during the whole treatment, because we know that chemotherapy schemes are really aggressive and the surgery is really aggressive, so these patients require good support. And our next topic will Dr. Laura Petrilia will talk on palliative care of these patients. I would like to introduce the colleague. She also works in Massachusetts General Hospital and also assistant professor from Harvard Medical School. So Laura, welcome to our hall in Ukraine. So you're welcome to talk.
Thank you so much, Dr. Patsko. It's a real pleasure to be with you today. I am going to start the slideshow. Let's see. Are you seeing my slides well?
Yeah, yes, we can.
You are? Okay, terrific. So thank you for the introduction. I'm Laura Petrillo. I'm from Massachusetts General Hospital, same as Dr. Ryan. And I'm thrilled to be with you today to be speaking about palliative care for people with pancreatic cancer. As a roadmap of what I'll be speaking about, I'll first be describing what is early palliative care. I'll be talking about the unique needs of people living with pancreatic cancer, followed by some evidence supporting early palliative care for people with pancreatic cancer, and then some specific palliative care approaches for patients with pancreatic cancer. I'll describe palliative care as a young and changing field. The origin of palliative care is that it arose in the 1960s and 1970s in response to insufficient end-of-life care for people dying of cancer. So the first hospice was St. Christopher's in London, founded by Dame Cicely Saunders. And she paid attention to people suffering at the end of life and noticed that it wasn't getting enough attention, that all the focus was on curative intent therapy, and opened a hospice to care for people who were dying. And their clinicians developed expertise in managing the pain and symptoms of people at the end of life. And initially, the first definition of palliative care was kind of that specialized expertise that clinicians developed to care for people who were dying. This was, again, in the 1960s, 1970s, even 1980s. However, a study that really changed everything about palliative care was published in the New England Journal in 2010 by my colleague, Jennifer Temmel, and others at Massachusetts General Hospital also. And it was comparing the early integration of palliative care for patients with advanced lung cancer compared to usual care. In this study, we provided palliative care visits every month for patients in the intervention arm, focused on symptom management, illness understanding, in connection, in collaboration with the oncology team. So alongside curative intent treatment, moving the kind of attention to quality of life and symptoms early in the course of illness. And what they found was heard around the world. This improved patients' quality of life. It improved their mood, it decreased depression. It improved their understanding about the goal of therapy, which ultimately resulted in less intensive healthcare utilization, so less chemotherapy in the last weeks of life. And what was really surprising, they looked to make sure that it didn't shorten people's lives, because people thought at the time that it was either focus on quality or focus on quantity. In fact, in the palliative care arm, those patients lived longer. It's not something that the primary investigator necessarily emphasizes because the goal was to find improvement in quality of life, but it was a huge finding and it changed the entire field of palliative care. So now we think about palliative care being integrated early from the course of illness, from the time of diagnosis, in contrast to the prior idea of focusing on cancer-focused care and then at the very end of life focusing on hospice. As Dr. Patsko said, we now think about the integration of palliative care early from the time of diagnosis, alongside disease-modifying care. And then when someone is at the very end of life and the focus of care is exclusively on quality of life, that's when we call it hospice care. So that the modern palliative care definition, based on that evidence and others, is that it is specialized medical care for people living with a serious illness, appropriate at any age and any stage of illness, focused on providing relief of the symptoms and stress of the illness, like cancer. And so the goal is to improve quality of life for both patient and family. We focus on symptom management, psychosocial support, illness understanding, advanced care planning, and the spiritual aspects of living with cancer, as well as transitions such as at the end of life. In addition to the study I showed you previously, so many studies, this is a list of old studies, but the list goes on and on and on of studies that have found benefits of integrated palliative care in terms of improving quality of life, decreasing symptom burden, improving depression and anxiety, improving caregiver and patient satisfaction, and then decreasing the burdensome and less useful end-of-life outcomes. Importantly, it doesn't compromise survival. This is a metaphor to help illustrate early palliative care. You can share this with your patients. At the top is the kind of older idea of palliative care being something that you think about late. So here, a patient and their family member are talking with the doctor and learning about their diagnosis. A few months later, they're caught in the rain. The doctor runs after them with an umbrella and says, "Here, this will help." In contrast, an early palliative care referral, the doctor hands the patient an umbrella and says, "You may not need this yet, but just in case." And a few months later, when they're caught in the rain, they have had their umbrella in hand and they said, "So glad we had this when we needed it." So you could think of palliative care being the umbrella that's there when you need it. You may not realize at first that it's going to be necessary, but having it in place is better than trying to catch up later. So turning to our focus of our conference today, why is palliative care especially necessary for pancreatic cancer? Well, as you know, pancreatic cancer is often diagnosed in the late stages. So patients often have advanced cancer at diagnosis, and there's a high risk of mortality. The survival rates just came out for the year 2023 in the US. The 5-year survival rate is 12%. It's abysmal. It's one of the worst among all of the cancers. It's the third leading cause of cancer death in the United States. And patients present with a high symptom burden. 75% of patients present with pain at diagnosis. Many of them have severe pain, and it's a significant factor in patients' quality of life. Many patients actually have inadequate pain control with analgesics, so that we can certainly be doing better. Patients also have symptoms like nausea, abdominal distension or bloating, dyspnea, weight loss, malnutrition, anorexia, other GI symptoms, and anxiety and depression. There have been a few studies similar to the one that I described that was conducted in lung cancer that have been focused actually exclusively on pancreatic cancer or on pancreatic cancer in addition to other cancers. There was one important positive study, which was out of Italy by Maltoni in the European Journal of Cancer in 2016, which compared early versus on-demand palliative care. So at the discretion of the clinician to make a referral versus early palliative care, like I was describing, for patients with metastatic or locally advanced pancreatic cancer in 200 patients. And that found improved quality of life with no difference in survival. There have been a few negative studies, although I will point out that some of the issues with these studies have been problems with measurement. So for example, in a study from Korea, which was early versus on-demand palliative care, they set a primary outcome of 50% reduction in pain at 4 weeks. And that was not met in this early integrated palliative care arm, but some other secondary pain outcomes and global quality of life were improved. So they may have chosen an ambitious target. Similarly, another study by Chachanov et al. In Canada had a primary outcome of quality of life improvement at 16 weeks that didn't meet significance, but then there were other outcomes that were significant. And when they looked specifically at the metastatic disease group, this was a group that had both early stage and advanced pancreatic cancer. The metastatic cancer patients had better outcomes and had responded. And so the guidelines that we have that recommend early integrated palliative care are all for patients with advanced cancer. So this makes sense. Similarly, there was a study by Temmel et al., the same investigator who did the first lung study, and it was a follow-up study looking at patients with GI cancer and lung cancer, which found improved quality of life for all patients at 24 weeks. But the subgroup of patients with pancreatic cancer in this group actually had no change in that palliative care versus usual care group, but that was actually because both groups of patients improved, which was kind of surprising. It may have reflected kind of disease response to treatment, but notably the lung cancer patients all got worse in the usual care arm and stayed the same in the palliative care arm. There are a lot of nuances to studying improvement in a group of patients that typically tend to just get worse and worse over time. Now turning to some specific approaches to pain management or to palliative care management in people with pancreatic cancer, I'm just going to start with some basics about pain management. And so some foundational ideas of how to approach pain for people with cancer-related pain. It's really essential to routinely screen for pain with a comprehensive pain assessment. And of note, what the patient says is their pain is the gold standard. We don't use anything other than patient self-report to understand and evaluate pain. So we ask patients about their experience, the location, radiation, intensity, how it affects their daily activities, the timing, onset, duration, and whether it's constant or intermittent, the quality of the pain, what makes it better, what makes it worse, and how it's responding to the therapy that is being provided. We also do a clinical assessment, including exam, labs, and imaging to try and understand the source of the pain. These recommendations come from the National Comprehensive Cancer Network framework for adult cancer pain. The citation is below. You may have seen the World Health Organization ladder for approaches to pain management. That's a little outdated. We don't tend to think of starting everyone with a certain kind of approach to pain management and then stepping up the ladder. It's more an assessment that is individualized, as I was describing to you before. We do a comprehensive assessment and then select the most appropriate regimen based on the severity of the pain, as well as the comorbid conditions, safety considerations for the patient, thinking about drug interactions, med availability, the expensive medications, and then how you expect the pain to change over time. The options we have for treating pain are opioids for severe pain, acetaminophen, nonsteroidal anti-inflammatory drugs like ibuprofen, and then adjuvant treatments like the antiepileptics we use for neuropathic pain. We consider scheduling analgesic for continuous pain. We try and anticipate adverse effects of the pain medications, such as constipation related to opioid use, and preemptively treat those adverse effects. And then, of course, we provide psychosocial support for patients and their families to try and help with coping with the pain. Opioids are a mainstay of our cancer pain management. Opioids come in either short-acting form or long-acting, which can be extended release or the inherently long-acting drug methadone. We think about using a short-acting drug, meaning one that has a few hours duration, for somebody who is opioid naive when we're trying to do dose finding for the total daily opioid dose, or as pre-medication for something for a painful activity like physical therapy. The short-acting medications that we have are morphine, oxycodone, hydromorphone, and then combination products with acetaminophen. The long-acting drugs is when somebody is using, for me, it's usually 4 or so doses per day of a short-acting drug. I start to think about adding a long-acting opioid. We calculate the dose, and that is equal to half to the full dose of the 24 hours of what somebody has consumed from short-acting medications. And then we continue the short-acting opioid so that they can then we can then titrate the long-acting dose based on their use of the short-acting opioid. So the extended release ones that we have are a long-acting morphine, a long-acting oxycodone. There is a long-acting hydromorphone product, but we don't have it in the United States. So it's not something that I use commonly. We also have a transdermal fentanyl patch, which is useful for patients who don't have an oral route. And then methadone is an excellent drug, a little beyond the scope of our talk today, but we use that frequently for cancer-related pain. Something that is highly specific and important for pancreatic cancer that we use frequently also is a celiac plexus block. So nerve block for the nerves that are innervating the abdominal viscera, including the pancreas, can be really helpful and last for 3 to 6 months. It's usually performed, it's a procedure that's performed usually by an anesthesiologist, or it could be performed during surgery. And it's for patients who have ineffective analgesia or intolerable side effects of opioids. And so it's the intentional chemical injury to the celiac plexus. It can be performed, a celiac plexus block can be performed percutaneously, so through the skin, via several approaches, anterior or posterior, which can be transcrural, retrocrural, or transaortic. It can be performed surgically or endoscopically in addition to percutaneously if there isn't someone with that expertise. And it's contraindicated in people who have coagulopathies or are on anticoagulation, who have intra-abdominal infection or bowel obstruction, or who can't tolerate the position. And then the risks, mostly what we see is the local pain after the procedure, which lasts a few hours. Sometimes people will get diarrhea from interruption of the sympathetic nerves, but that's also brief. Very rarely there can be vascular or organ damage. Exceedingly rarely there can be paraplegia or pneumothorax if the needle goes in the wrong place. It is really beneficial for patients. So there was a meta-analysis of the randomized control trials that had been done of celiac plexus block. This is actually from 1995, but it found among the who had celiac plexus blocks in these RCTs that there 70 to 90% of patients had complete or partial relief at the time of death, even for past 12 weeks. Another important symptom that patients with pancreatic cancer deal with is nausea. And similar to pain, we don't just treat the symptom, we try and understand what's happening. We try and get a full character of what's going on with the nausea and try and have a differential diagnosis so that we can then do a targeted drug selection. And if the cause is unclear, we try and obtain more data. Understanding the mechanism for nausea is key. So we think about, is the nausea caused by a problem with the GI mucosa or mechanical stretch? Is it caused by drugs like chemotherapy? Is it something related to anxiety or motion disorders? And each of these point to a different neurotransmitter involved in different pathways. And once you know the neurotransmitter that's involved in the cause of the nausea, you can be more elegant about selecting a therapy for nausea that targets the antiemetic receptor activity. So for example, for patients who have motion sickness, thinking about the muscarinic acetylcholine receptors and choosing something like scopolamine, or thinking about dopamine receptors and selecting something like Haldol, serotonin, thinking about ondansetron. And then a lot of our drugs actually target a number of different receptors, which is why we reach for them more in more general situations like our compazine or our olanzapine. I want to call your attention to another really fascinating study that came out last year in JCO from India, which was targeting the symptom of anorexia or having a low appetite and disinterest in food. This is such a common symptom. It's really common among people with pancreatic cancer. And in this study, they looked at olanzapine, which is a later generation atypical antipsychotic that I was just saying we use for nausea that targets a bunch of different neurotransmitters. And they looked at using nightly olanzapine versus placebo in people with locally advanced or metastatic gastric, hepatopancreatic, biliary, or lung cancer who are undergoing chemotherapy. And they found that people who got olanzapine were gained more weight, they had an improved appetite, and they found that they also had improved quality of life, improved subjective nutritional status, and less chemotoxicity. This actually prompted a pretty quick guideline change to recommend olanzapine. Olanzapine was something we were already using fairly commonly for chemotherapy-related nausea. It also is helpful for anxiety and is sedating, so we give it at nighttime so people can sleep. So it's a really incredible drug that does many different things, but this was the first time somebody looked at it specifically for anorexia and found that it was helpful also when given sort of preemptively. Another important aspect of the supportive care for people with pancreatic cancer is nutrition. There is a great website, the PanCan organization, it's a patient advocacy organization, who included these post-Whipple recommendations, since Whipple is such a common experience for people with pancreatic cancer. And some of these recommendations are relevant whether someone's had surgery or not. But counseling patients to avoid or limit greasy and high-fat foods, taking pancreatic enzymes, and making sure that someone's taking sufficient pancreatic enzymes. Often patients don't understand how many pancreatic enzyme pills they need to take. Making sure that they're taking small, frequent meals that are spaced through a few hours apart, drinking plenty of fluids, aiming for plenty of fruits and vegetables, as we could all be doing, taking acid-reducing medications as needed, taking vitamins if they're necessary, and then thinking about other healthy lifestyle behaviors like avoiding alcoholic beverages and engaging in physical activity at least 30 minutes a day, and even a little bit helps, and considering strength training to help as well. So in conclusion, I just want to emphasize that early palliative care is beneficial for people with advanced cancer and should be considered for all patients from the time of diagnosis. And I urge you not to wait until someone is at the end of life to think about it. I was describing a lot of studies where palliative care was provided by specialist palliative care clinicians, and I recognize that they're in short supply. So sometimes we'll think about what are primary palliative care skills, what are palliative care ideas that can be delivered by clinicians like oncology clinicians or primary care doctors that really focus on this supportive care for improving quality of life. It's essential, and it's described as a human right. Then routine symptom evaluation and management is critical. Pain, nausea, anorexia. I showed you some studies that really demonstrate that the proactive management of these symptoms improves outcomes. And thinking about outside of the box therapies like celiac plexus block, which if there isn't a specialist with the capacity to do it percutaneously, as I was showing, it can also be done surgically or endoscopically, and can really provide patients with a lot of relief. Maintaining nutrition is also a really important component of health and overall quality of life. You were seeing some really exciting results from Dr. Ryan about people living longer with advanced pancreatic cancer. And so we have to be thinking about these other aspects of their lifestyle, and maintaining nutrition is so important, as well as physical activity. So I have definitely a lot of time for questions. I want to just acknowledge some of my colleagues who shared some of the slides with me at the Massachusetts General Hospital. And those are my kids celebrating Valentine's Day yesterday. But I want to just open it up for questions. I can stop sharing my screen.
Thank you very much for your great talk. We have one question already ready to be asked. So
yeah, I'm Andrei Lukashenko from Kiev, and I want to ask you: do you have any experience in symptomatic neural transection transthoraxically for decreasing pain relief in pancreatic cancer patients?
Yeah. Are you describing a nerve block apart from a celiac plexus block? Is that what you're talking about?
I mean, a transthoracic bilateral sympathetic dissection. Usually done thoracoscopically from both sides.
That's terrific. The celiac plexus block that I was mentioning can be done via a number of different approaches. So I'm wondering if we're describing something similar in terms of a different approach. And I'm curious, is that something that you are using to help with pain management for patients?
We do the same thing through the skiing, but if it's not effective, sometimes we do it thoracoscopically and remove all symptomatic nerves from thoracic cavity.
Thoracic cavity.
Also could decrease the pain relief up to the 33% when it's not effective through those methods as you described in your presentation.
That's terrific. Thank you so much for sharing. I'll look into that further. You know, we often will think about the celiac plexus block at a specific juncture in patients' care. And it's often, you know, as I was mentioning, when patients have not had relief from opioid analgesia, and we'll typically try it. If it's helpful, that's great. If it's not helpful, sometimes we will even repeat the celiac plexus block, just imagining that potentially it didn't get to the right spot. I'll admit that I'm not an anesthesiologist, so I refer patients for this procedure. I'm not performing it myself, but we do repeat it on occasion. And an important thing, as I'm sure you know, is that at a certain point, there's kind of regeneration of the nerves. And so I wonder if the approach that you're describing, the transthoracic approach, is kind of getting some of the different nerves that may be that may have been missed kind of the first time around when you have insufficient relief from the celiac plexus block. Yeah, thank you for sharing that.
A question from the audience.
My name is Sviatoslav Balak. I'm from Ivano-Frankivsk here. I work right now. I'm an interventional radiologist. We don't perform usually. I have never tried celiac block because usually cancer spreads, and we perform splanchnic nerves, retrocrural. There is a good space. There is a compartment that allows us to for spreading of alcohol, for example, and better results. And I see at least a significant improvement of the patient's condition or almost disappearance of the pain after this procedure.
Thank you so much for sharing that. So the retrocrural approach to the splanchnic nerves.
It also blocks the tail of the pancreas, the whole part of the upper level of the abdominal cavity.
Thank you very much for sharing that. I'm so glad that your patients are able to get relief from that procedure.
And I have one question for myself. It could be a little bit practical, I guess, for a clinical oncologist. So do you have any suggestions how to pursue a patient to go for the palliative care unit? Because usually when I talk with my patients that, well, you need to consult palliative care doctor, they say, well, are you talking about hospice? So I'm not going to die right now. So they are thinking they are just connecting this with a death. How to pursue them that it's not about death, it's about relieving their symptoms.
Thank you very much for that important question. I think one critical piece is it's not only about convincing the patients, it's also about creating the whole system that is thinking about palliative care and kind of quality of life focused care as appropriate, necessary, and essential throughout the course of illness. So it's not only the patients, it's also our colleagues. So I think that the concept and the stigma gets reinforced that palliative care is the equivalent of hospice care by clinicians who refer late, and then it becomes a kind of reinforcing principle because people will have the experience of family members who've been referred to palliative care in the weeks, days or weeks before death, and then that gets reinforced. So I think it's on us as well to be emphasizing that. But for patients and families, honestly, when my colleagues refer patients to our practice, they describe, I can see that you're dealing with pain. Can I ask you to see my colleagues who have pain expertise and who have a lot of experience managing the medications for pain control and nausea to help you have better quality of life, to be able to do the things that you enjoy? It's kind of a no-brainer when you really emphasize what we do versus the title of the service. And then once people have their foot in the door and they start to see the questions that we ask about, see the topics that we're helpful with, that really gets everyone sort of over the hump to be able to understand how it can be helpful for them.
Very much for your answer. Currently, we don't have any more questions. I really appreciate your participating in our conference. And I would like to thank for all who was present online and offline. So we're going to finish today's event. I will give a word to President of Ukrainian Society of Surgical Oncologists to give a final word. And we're going to end.